Hold from deliberation after the policy question is being deliberated, and will abstain from votes related to any COVID-19 vaccine. Next slide. And that is it today. We will first have Dr. Beth Bell is going to open us up today, Dr. Romero. We're going to have a presentation from the company and then take very focused questions, and then we're going to go through the rest of the presentations before discussion. Back over to you, Dr. Romero.
Thank you very much, Dr. Cohn. Let's begin with the chair of the ACIP working group for COVID vaccines, Dr. Beth Bell, to give an introduction. Dr. Bell, please.
Thank you very much, and good morning and good afternoon. Could I have the next slide, please? Before I introduce today's agenda, there's a couple of important issues, contextual issues, that we felt it was important for the committee be aware of in order to kind of best assimilate the information that's going to be presented. So I'm just going to cover a couple of areas, reviewing the adenovirus vector vaccines, describing the rare clot events seen after these vaccines, and a bit about the ACIP response, and then I'll go over today's agenda. Next, please. There are two adenovirus vector vaccines, the Janssen J&J vaccine and the AstraZeneca vaccine, as I'm sure most of you are aware. The Janssen vaccine is a single-dose vaccine. It uses human adenovirus 26 as its vector. An EUA was issued in the United States in February of 2021 of this year for the Janssen vaccine, and ACIP subsequently made recommendation. The EMA, which is the European Medicines Agency, has authorized the Janssen vaccine for Europe, but no doses have been delivered or administered in Europe. Now, the AstraZeneca vaccine is a two-dose vaccine. The vector is the chimp adenovirus. We are awaiting an EU application in the US, but it is approved in the UK and Europe, and as most of you are aware, has been in wide use in those areas and other parts of the world. Now, there have been concerns raised about rare clotting events seen after COVID-19 adenovirus vector vaccines. The clinical syndromes after both vaccines appear similar. You will hear more about this during the upcoming presentations. But the extent to which the cases seen after each of these adenovector virus vaccines represent exactly the same syndrome is not entirely clear at this time, and is something else that I'm sure will be discussed. Next, please. Now, there has been some activity with respect to the AstraZeneca vaccine, which I just wanted to review. Last week, the European Medicines Agency, the EMA Safety Committee, released a report that concluded that there was a strong association and probable causal link between the AstraZeneca vaccine and rare clotting events. There were press releases from both the European Union and the United Kingdom, and I've summarized them here. From the European Union, there have been 62 cases of CVST, which is central venous sinus thrombosis, and 24 cases of splanchnic vein thrombosis, all with thrombocytopenia. 18 of these cases were fatal. Most occurred in females younger than 60 years. They occurred primarily within 2 weeks of receipt of the AstraZeneca vaccine. And in the EU, unfortunately, because of different ways that the vaccine is used in each country, the EU was not able to exclude age and gender as risk factors. They just don't have the denominators, I imagine. From the United Kingdom, they reported 79 cases of thrombosis and thrombocytopenia. 19 were fatal. Among these, there were 34 cases of CVST with 14 fatalities and 35 cases of other clotting disorders with 5 fatalities. 51 cases were female and 28 were male. This is on the context of a denominator of 20.2 million doses given in the UK. The press release estimated a risk of about 4 per million persons, with the comment that there was a slightly higher incidence in younger age groups. Next, please. There very recently were 2 reports in the New England Journal of low platelets, that is thrombocytopenia and blood clots thrombosis, after the AstraZeneca vaccine in Europe. These 2 cases came from, I believe this is a typographical error, from Germany and Austria and Norway. Many of these cases had platelet activating antibodies directed against platelet factor 4, PF4, which is a clue to the possible mechanism here. And the authors proposed a syndrome entitled vaccine-induced immune thrombotic thrombocytopenia. Next, please. I just wanted to take a moment to review central venous sinus thrombosis, CVST, since this is one of the more predominant syndromes or conditions that have been identified. This involves thrombosis within large vessels that are draining blood from the brain. And you can see in this figure here, which may or may not be readable, the various parts of the circulation. It mostly occurs among people 20 to 50 years of age, mostly female. Risks include pregnancy and other identified risks for coagulation, such as oral contraceptives. Symptoms typically include headache, nausea, vomiting, and other neurologic symptoms, and the presentation can be acute or more chronic. And I'll just make a point that this is kind of an overall description of CVST, not specifically CVST with thrombocytopenia, which is what has been seen in the current situation. Next, please. So what has happened as a result of these findings in Europe? The EMA's Pharmacovigilance Risk Assessment Committee doesn't make vaccine policy for the EU. Each country makes its own policy. But many countries have made new policy and have adopted age-based recommendations. In the UK, on April 7th, the recommendation was made to use the AstraZeneca vaccine in adults 30 years of age and older. In Australia, adults 50 years of age and older. And in other European countries, a range of from 55 to 70 years of age, depending on the country. Next, please. Now, I just want to say a little bit about the Janssen J&J COVID-19 vaccine, which of course is the focus of our meeting today. As I mentioned, it received an EUA from FDA in February, and ACIP made recommendations. On April 13th, CDC and FDA issued a joint statement on the J&J COVID-19 vaccine. Made the following points: that as of the day before, that more than 6.8 million doses of the vaccine had been administered in the United States. The CDC and FDA were reviewing data involving 6 cases of CVST in combination with low platelets reported among recipients of the J&J vaccine in the United States. And the statement said that CDC will convene a meeting of the ACIP on Wednesday to further review these cases and assess their potential significance, which is what we're doing today. And that until the process is complete, that there's a recommendation to pause the use of the vaccine out of an abundance of caution. Next, please. One of the other things that came out of this press release, a point that was made in the press release, that one of the important reasons for the pause was to allow time to provide information to clinicians and to the public about specifics around, and unique aspects of diagnosis and treatment and clinical signs and symptoms to monitor. And the first step in that process occurred with the issuance of a HAN, a Health Alert Network release on April 13th, which provided recommendations for clinicians on diagnosis and treatment, recommendations for public health on how to report cases through VAERS, the Vaccine Adverse Event Reporting System, and recommendations for the public on clinical signs and symptoms to monitor and when to seek medical attention. You'll be hearing much more about the details and specifics of HAN later on during one of the other presentations today. Next, please. Here's a few of those details for clinicians for diagnosis and treatment to evaluate patients with a screening P-F4 ELISA that would be performed for autoimmune heparin-induced thrombocytopenia, consulting a hematologist, and importantly, don't treat with heparin unless this test is negative. Encouraging reporting through VAERS, and for the public to know to contact a healthcare provider or seek medical care if you develop a severe headache, abdominal pain, leg pain, or shortness of breath within 3 weeks of vaccination with the J&J COVID-19 vaccine. Next, please. So the ACIP response this week so far has included a meeting on Monday of the Vaccine Safety Technical Advisory Group, and you will hear a report of the outcome of that meeting and a summary shortly. Yesterday, there was a meeting of the ACIP COVID-19 Vaccines Work Group. Again, you'll be hearing about this. And obviously today, we're having an emergency ACIP meeting with a purpose of considering the implications of reported cases of thrombosis and thrombocytopenia after the Janssen J&J vaccine. Next, please. So the agenda today will include an overview of the safety of Janssen's COVID-19 vaccine by Dr. Aaron Marie from Janssen Pharmaceuticals of Johnson & Johnson. Presentation on cerebral venous sinus thrombosis with thrombocytopenia after COVID-19 vaccines from VAERS by Dr. Tom Shimabukuro. The assessment of the Vaccine Safety Committee from Dr. Grace Lee, who is the VASC chair. The work group interpretation from Dr. Sarah Oliver, who's the CDC lead on the work group. Public comment, discussion, and then potentially a vote with updated interim recommendations if appropriate at that time. Next. I'm putting here again our list of the work group members, ex officio members, liaisons, and consultants. Next, please. And all of the CDC participants, and as always, I'm very grateful to everyone for their participation and contributions in this process. Next, please. Thank you very much, and I turn the floor back to Dr. Romero.
Thank you, Dr. Bell, for that introduction. We'll move forward then with the presentation by Dr. Aaron Marie from Janssen Pharmaceutical Companies, an overview of safety with Janssen's COVID-19 vaccine, Ad26-CoV2S. Dr. Marie.
Thank you, Dr. Romero. Can you hear me okay?
Yes, I can. Go ahead.
Thank you. My name is Aaron Marie. I'm the Chief Medical Officer for Janssen and head of our Global Medical Safety Organization. And it's a great pleasure for me and my colleagues to be with you this afternoon to present to the committee. Next slide, please. So in the next 15 slides, which I'm going to step through reasonably quickly in order to respect the committee's time and ensure you have time for questions and answers. I'd like to take you through the relevant Janssen clinical and post-authorization data on the subject of thrombosis, particularly CVST with thrombocytopenia, and also describe our background epidemiological data set in the context of our overall evaluation. Next slide, please. Firstly, I'd like to emphasize that the safety and the well-being of the people who use our products is the #1 priority for our company. While causality has not been fully established between these very rare events and our vaccine, we recognize these events could represent an important potential risk with the Janssen vaccine. We're in the process of updating our company core data sheet and working with health authorities to update our labeling appropriately. Johnson & Johnson will continue to monitor this potential risk, and we are committed to efforts to ensure vaccinee and healthcare professional awareness of the important signs and symptoms of this event, as well as appropriate diagnosis and management. Next slide, please. I'd now like to take the committee members through a review of the data. I'll start with the clinical trial data, and as the committee is aware, we have 2 pivotal phase 3 clinical trials in our program. Study 3001 is the single-dose phase 3 trial, and I'll present here on this slide the adverse event data with respect to venous thrombosis events. And the subsequent slide will be our study 3009, which is still ongoing as well. This study remains blinded, but I will also present to you the venous thrombosis events. So study 3001, we have vaccinated 43,783 participants. And I list along the left column here, row by row, the DVTs, PEs, cerebral venous sinus thromboses, venous thrombosis, and embolism venous terms. There are 4 columns. The first 2 columns are the adenoviral vaccine, the placebo, and the number of cases up to 28 days after vaccination. And the third and fourth columns are the total number of cases to date. So as the committee will see, in the 28 days after vaccination, we have collected 4 DVTs in the active arm of 3001 and 2 cases in placebo. We have 2 cases of PE, 1 case of placebo. We collected 1 CVST and 1 venous thrombosis of a limb, both of those in the active arm. Total number of cases include 11 DVTs in the active arm, 3 in placebo, 8 pulmonary emboli in the active arm, 4 in placebo, 1 CVST already mentioned in the active arm, 1 in placebo after 28 days, and then the venous thrombosis of the limb and a 1 venous embolus. Next slide, please. In study 3009, which is the ongoing phase 3 2-dose pivotal trial, we have vaccinated 28,277 participants. This study remains blinded, and the data are presented as blinded. In this study, we have had 1 pulmonary embolus event up to 28 days. We have had 2 DVTs at all time points, and 4 PEs also beyond 28 days. Again, this study remains blinded. Next slide, please. There is also an ongoing study, a large open label study in South African healthcare professionals. This has enrolled currently 272,438 participants of a total anticipated 500,000 participants. And I'm presenting the safety data to you here as of the 9th of April. As of that date, we have had no reports of CVST. We have had 1 case of pulmonary embolism, There has been no information on platelet or COVID status with this case. We have had one case of CVA in a 38-year-old female, 8 days after vaccination, and are actively seeking additional information on this case through the PI. And we have had one report of retinal vein thrombosis in a 68-year-old diabetic, and the platelet count for this case was reported as normal. Next slide, please. I'd now like to take the committee through all known cases of CVST and all known cases of thrombosis with thrombocytopenia with the Janssen COVID vaccine to date. This is the slide derived from the CDC public website showing the number of vaccinations to date administered in the United States with the Janssen COVID-19 vaccine. And as of this morning, I believe that number is now 7.2 million doses administered. And as of 14th of April, Janssen is aware of 6 post-authorization cases of cerebral venous sinus thrombus, 4 of 6 with low platelets, and 2 unknown within these individuals vaccinated. Next slide, please. This is the table as described of all known cases of thrombosis with thrombocytopenia with the Janssen COVID-19 vaccine. The first 2 rows are the cases already described within the phase 3 clinical trial program. The following rows are the post-authorization cases. In study 3001, the first row, the case was of a 25-year-old male on vaccine. The report was of a CVST with hemorrhage. It was noted that the subject had stenosis of his transverse sinus, and there was a suspected upper respiratory tract infection. The platelet count, nadir, was reported at 64,000. We have recently retrospectively determined that his antiplatelet factor 4 antibodies at baseline were negative, and post-vaccination, I believe, around day 28, but may be corrected, were positive. His COVID status was negative. Time to onset was 8 days after vaccination, and this gentleman was treated with heparin, TPA, received platelets, had 2 balloon angioplasties and thrombectomies due to the discovery of a venous sinus stenosis. And he has recovered and has been discharged from hospital. The second row from study 3001 is the participant who has recovered from a CVST. She was a 24-year-old female, but was on placebo. She had a normal antiplatelet factor 4 antibody test post-vaccination, post-incident. Her COVID status is negative. The time to onset was greater than 50 days after vaccination. I'd next like to describe 7 post-authorization cases, including 1 of deep venous thrombosis. The committee may be aware that cases in the post-authorization phase come to Janssen primarily from 2 sources. The first 3 cases described and the final case come through the VAERS Vaccine Adverse Event Reporting System, the joint CDC FDA reporting system. We gain access to these reports when they're refreshed every Friday. There is a slight lag in reporting to us, and understandably, for privacy reasons, there is significant redaction of some of the data fields, and it is not possible for us to follow up for further information or evaluation beyond what is presented to us in the preliminary report. We can attempt to do so through Freedom of Information applications, and FDA has been very supportive in helping us to try to expedite these requests. The other cases come to us directly, either through our call center or through our website or email. And these clearly allow us the opportunity to go back and get further information and are therefore a richer data set. So after I have described the post-authorization cases to the committee, I will quickly step through 3 cases that contain significant details of interest to this discussion. The first case in the post-authorization phase, the first row in blue after the green row, was a 45-year-old female. She presented CVST with hemorrhage. No risk factors were described in the report. The report notes the term thrombocytopenia. COVID status was unknown. Time to onset after vaccination was reported at 11 days. Treatment was not described, and this patient died. The second case also came through VAERS. It was a 38-year-old female. She presented with CVST, risk factors unknown, platelet count unknown, COVID status was not described in the report. Time to onset was 10 to 14 days after vaccination. She was treated with heparin, and at this time, she is described in the report as not recovered. The third case was a 59-year-old female. She presented with extensive deep venous thromboses on her left side. She had known coronary artery disease. Her platelet count nadir was reported at 15,000. COVID status unknown. Time to onset after vaccination was 7 days. A vena cava filter was inserted in her inferior vena cava, and she also underwent thrombectomy. The day after the procedure to place the inferior vena cava, she was reported to have significant thromboses on her right side, significant DVTs on her right side, and it was questioned as to whether or not this was secondary to the intervention or partially precipitated by the intervention through her right side to place the inferior vena cava filter. At this time in the report, her status is not recovered. The next case is reported as a Janssen serious adverse event report. It came to us from Nevada. It was an 18-year-old female. She presented as a CVST with hemorrhage, risk factors unknown. Platelet count nadir was 16,000. The COVID status was unknown. Time to onset after vaccination was 14 days. She was initially treated on heparin and then switched to what is reported as treatment according to the British guidelines, which I take to refer to the guidance announced by the expert hematology panel affiliated with the British Society of Hematology, and she then also underwent a thrombectomy. At this time, her status is described as not recovered. The next case was reported directly again to Janssen. This was reported through pre-publication by the New England Journal via an editor notification directly to the company, and the case is in Nebraska. This is a 48-year-old female. She was reported as presenting with TTP, splanchnic vein thrombosis, CVST. She was initially given heparin, and then additional hepatic and splanchnic vein thrombosis was reported. Risk factors unknown. Her platelet count nadir was reported at 13,000. She was also reported to have a high D-dimer and a positive antiplatelet factor 4 antibody test. COVID status was reported as negative. Time to onset 14 days after vaccination. She was treated with heparin at first, and then after the antiplatelet factor 4 antibody test resulted, she was switched to argabatran and then also given IVIG. At this time, her status in the report is not recovered. The next case was also reported to Janssen directly, comes from New Jersey and Pennsylvania. The case is a 26-year-old female who presented with CVST, PE, portal vein thrombosis. Risk factors described are obesity. Platelet count was 120,000. She also had a high D-dimer and a positive antiplatelet factor 4 assay. Her COVID status was negative. Time to onset after vaccination was 7 days. She was treated with heparin and then with IVIG and has been discharged from hospital. The final case was notified to us through VAERS, has very limited detail on the company side. It refers to a 28-year-old female, and details are pending under a Freedom of Information application via FDA to CDC. I'd now like to take you through 3 of these cases which have more detail. The first case I'd like to go to is the New England Journal case, the pre-publication case that I mentioned from the University of Nebraska, which we received on Thursday, the 8th of April. This 48-year-old woman was described as having an unremarkable past medical history, presented to ER after 3 days of malaise and abdominal pain. The initial evaluation describes mild anemia and severe thrombocytopenia with a platelet count of 13,000. A blood smear confirmed marked reduction in platelet count with occasional schistocytes. She had hypofibrinogenemia, a prolonged APTT, and markedly elevated D-dimer, and was noted to have extensive splanchnic vein thrombosis on CT. She was transferred then to the reporting institution with further evaluation and progression noted of the thrombosis on heparin. She had a negative PCR test for SARS-CoV-2, a head CT for new onset headaches reported in her secondary hospital, showed cerebral venous sinus thrombosis. Thrombosis progressed with hemorrhagic stroke despite treatment with heparin. She underwent repeat CT angiography, which showed new thrombus involving the right hepatic and splenic veins. Further inquiry revealed the patient received our vaccine 14 days before symptom onset. The report describes evidence and then management of possible immune thrombotic thrombocytopenia, ITT. She had positive antiplatelet factor 4/heparin antibodies by ELISA. Her latex-enhanced ELISA immunoassay was negative. Her heparin was switched in the second hospital to argabatran. She was given IVIG 1 gram per kilogram of body weight for 2 days. Her platelet count was reported to have increased from 30,000 to 145,000 over 5 days, and she remains critically ill as of the last report. The next case, also reported directly to Janssen, and subsequently further details received on a phone call contact with a physician on Monday, the 12th of April, is of a 26-year-old woman who is described as overweight but active. I believe she's a gym instructor, with no history of clotting disorder and on no medication. She initially presented to the emergency room with severe headache approximately 1 week following vaccination. She has been discharged home from the ER. She was then discharged home from the ER with paracetamol and Benadryl. However, her headache persisted. She was subsequently admitted to hospital another week later with abdominal pain and a rapid heart rate. COVID-19 infection was ruled out, although we have no details of the exact test. Laboratory evaluation revealed thrombocytopenia with a platelet count nadir at 120,000, elevated D-dimer, and normal fibrinogen described, but the level exact level not known. The diagnostic scan showed CVST, portal vein thrombosis, and pulmonary embolus. She was initially treated with heparin, and this was described as having been switched to IVIG after the clinical team became aware of a positive anti-PF4 antibody test result. Her platelet count reportedly started to increase before the IVIG was commenced. This patient has been discharged home on oral anticoagulants after a period of 1 to 1.5 weeks in hospital. Next slide, please. This case is from our clinical trial program, study 3001, and is of a 25-year-old male, healthy, active male, who was vaccinated on September 21, 2020. 8 days after vaccination, the subject began to feel progressively unwell, describes fatigue, faintness, nausea, headache, for which he took NSAIDs. 11 days post-vaccination, that's 3 days later, he describes continued fatigue, weakness and nausea, and also abdominal pain and headache. A COVID-19 swab taken by the PI on that date was negative. He was then hospitalized 19 days post-vaccination after a visual disturbance and collapsing. This was on October 9th, 2020. Laboratory evaluation, the platelet count was reported at 64,000, PT 17.7, INR 1.46, fibrinogen 154, white blood count 12.4, hemoglobin 12.7, hematocrit 36.1. He underwent CT, MRI, and venogram, and his diagnosis was of a cerebral venous sinus thrombus and secondary cerebral hemorrhage. The gentleman underwent repeated cerebral vascular sinus thrombectomy and balloon venoplasty due to reocclusion and treatment for a tight stenosis in his venous sinus. He was also treated with low molecular weight heparin and IV TPA. Extensive hematology and infectious disease laboratory evaluations showed inconclusive results. Please excuse the typo, that should read inconclusive results. The patient was discharged on treatment with apixaban. Last week, stored serum tested positive for anti-PF4 antibodies for the post-vaccination phase, and the baseline laboratory anti-PF4 antibody test was negative. This gentleman recovered after repeat thrombectomy and balloon angioplasty. He was described as having severe epiglottitis while in hospital, and his discharge meds included apixaban. I would next like to briefly invite my colleague, Dr. Courtney Davis, to describe the epidemiological analysis that we have conducted to assist this investigation. Thank you.
Thank you, Dr. Marie. I'm happy to join you today. I'm Courtney Davis. I'm an epidemiologist from our global epidemiology group at Janssen. And we conducted a published literature search. Actually, the articles that were retrieved included studies and populations from the US and EU, as well as from the Middle East and Asia Pacific. We also conducted an internal analysis of large healthcare databases. And what you'll see on the next slide are results from a meta-analysis across 4 large US healthcare claims databases and 1 US electronic health record database. And that study design was to generate background incidence rates of CVST. We used the study period of 2017 to 2019 to generate the incidence of the outcome CVST. The methods used for that analysis are similar to those that were used in a multinational network cohort study of 15 different adverse events of special interest. And those, the results of that larger network study have been shared with FDA and EMA and are published on a preprint server, and a manuscript of those AESI background rates are also under review. Could go to the next slide. Kind of hard to read. I apologize, it's a lot of numbers, but did wanted to be transparent in showing estimates from the published literature. Those are in the bottom rows of the table, and also those from database analyses conducted by Janssen and also by the Access group in Europe. So I will start with the bottom, actually, because that's the published literature, and that may be what folks are more familiar with. And those are shown for overall adults, the background incidence rate. These are shown per 100,000 person years. And those range from 0.2 to 0.5 or 2 to 5 per million. In the older studies, to higher rates, upwards of about 15 per million in the more recent studies that come from the bottom two references there. The results of our claims database are the first row, and those are not published yet. As I mentioned, those were just generated. And those are by age and sex, and we thought it was important to display that for you, since there is more attention as a potential higher risk among younger women. And what you can see displayed there are, in fact, higher rates observed from this claims database analysis, the highest being observed in the women ages 18 to 34, which shows 2.6 per 100,000 or 26 per million, and an overall rate for ages 18 to 85 in women of 17 per million or in men of 12 per million. That gives you an understanding of the range of the estimates from more contemporary claims database. But I would like to point out limitations of the claims data include there is no validation of the outcome of CVST. And that is, we did the best we could with the diagnoses which come from hospitalized events. And finally, I would just mention that right now we're working on stratified analysis of CVST incidence by thrombocytopenia, and that is underway right now. I'll hand it back over to you, Dr. Marie.
Thank you, Courtney. Next slide, please. And Dr. Davis's presentation reminded me to inform the committee that while we don't have ethnicity reported in all of the post-authorization reports, we do know that the single case of CVST in the active arm in our 3001 study was in a white male, the 25-year-old. And we do have the data on 2 of the post-market reports indicating that they were 2 white females, but the others are not, it's not described in those case reports. Thank you for the reminder, Courtney. Finally, the Janssen is conducting an intensive ongoing review of internal and publicly available data, including but not limited to evolving literature on the relationship between COVID and thrombocytopenic and thrombotic events. We're interrogating case reports of association between thromboembolic events, including CVST with ITP and TTP, and also searching the US vaccine adverse event reporting system data on thrombocytopenic and thrombotic events and other adverse events of special interest for all available vaccines, and also the European Eudravigilance adverse event data set. So in conclusion, Chairperson, I'd like to reiterate that based on the current data, Janssen believes the overall benefit risk profile for our vaccine is positive across the population for which it's authorized. We strongly support ensuring vaccinee awareness of the signs and symptoms of this very rare event, as well as the recommendations to ensure the correct diagnosis, treatment, and reporting by healthcare professionals. Thank you.
Dr. Marie, thank you very much for that detailed and comprehensive review of what is known. We're going to open it up to questions now from the voting members initially and then liaisons. At the risk of revealing my knowledge lacunae, can you tell me what, if any, is the significance of the latex enhanced negative assay on the first case that you presented, or for PF1 antiplatelet factor antibodies?
So Dr. Romero, if there are hematologists present, they will be more expert than I. However, it has been represented to me that for the PF4 test, it's important to use the ELISA test, but some of the other assays may not be as sensitive as the ELISA test for anti-PF4. So in the case where both were reported to us, we represented both.
Very good. Thank you for that clarification. Let me see if I can turn to my list of questions. Are there any questions? You can raise your hand, please. Dr. Bernstein.
Thank you for that presentation. Obviously, this is unique circumstances. I just had a couple of questions just for clarification. One of the patients, a number of the patients were described as having recovered, and one of the patients was described as discharged from the hospital. Is that considered recovered, or what is recovered mean? They're back to normal, or they're still being treated and monitored?
Thank you for your question, Dr. Bernstein. The reports, which are known as CIOMS reports that are reported to VAERS, have a number of fields, including a field for status with a limited number of options available. So some of what is represented is somewhat clunky form terminology due to the limited options available.
Thank you. And then on slide 15, with the background incident rates of CVST, were those cases, we do not know about their platelet counts. So these are the background incidence rates of CVST without thrombocytopenia, correct?
This
Let
is
me ask
Dr.
Dr. Davis.
Thank you. This is all CVST, and it is not stratified in this analysis by thrombocytopenia status. So that's what we're working on at the moment, is to split those and to be able to generate an incidence rate for CVST with concurrent thrombocytopenia or low platelet counts versus the cases that do not. Right now, this is just any CVST.
Thank you.
Dr. Sanchez, please.
Thank you, Jose. I have and thank you for the presentation. Certainly concerning. I had a few questions. First of all, did any of the women, were they had a recent pregnancy or were any postpartum? Second of all, did any have a history of like preeclampsia in a previous, in some pregnancy? And then if you have any information on other medications such as oral contraceptives that some of these women may have been receiving.
Thank you, Dr. Sanchez. We did scan all reports and send questions back to those for whom we had identifiable reporters asking those. And as per the presentation, we don't have reports of recent pregnancy or recent or the subject being in the postpartum period or having suffered preeclampsia. I don't believe any of the participants, other than the one woman, the 24-year-old female in the placebo arm in our clinical study who had a CVST at beyond 50 days, she was on OCP, but it is not described to the best of my recollection for any of the cases post-vaccination.
Dr. Romero, I just want to also add to the committee, let the committee know that the next presentation by Dr. Shimabukuro will go through the VAERS reports with some specificity, and we'll share any information we have about those cases.
Thank you for that information, Dr. Cohn. Dr. Sanchez or Dr. Marie, do you have any more to add?
No.
Very good. Very good. Sorry, I wanted to make sure I didn't cut anybody off. Dr. Paling, please.
Hi, thank you very much for this presentation. I wanted, when I was listening to the presentation, I believe the one case from New Jersey, Pennsylvania that was directly reported had CVST with pulmonary embolism. I wanted to ask, were there any cases of pulmonary embolism without CVST that you guys are aware of? And are you looking for those?
Thank you, Dr. Paling, for the question. We have had cases of pulmonary embolus, but none reported in the context beyond what's been described today, none reported with concomitant thrombocytopenia.
Thank you.
How many
Dr. Paling, continue.
How many cases have been reported and the time frame?
Let me just pull up the table for you here. Dr. Nettles, could you pull up table 18, and Dr. Chang, remind me if there are other tables. So this is while Dr. Nettles is pulling up the table, we have interrogated the VAERS database, looking for thrombocytopenic, thromboembolic, and hemorrhagic events that have been observed after vaccination, and we have a report as of the 9th of April. We've had 55 reports of thromboembolism. We've had 4 reports, the third row down, of thromboembolism with thrombocytopenia. We've had 2 cases of CVST, and then other adverse events specifically described in the rows below. And that's at an exposure of 4.9 million doses administered.
Dr. Paling, any other questions? Dr. Marie, please forgive me. Since I cannot see you, I'm not sure if you're done with your answers.
Thank you. Yes, indeed. In addition, in the phase 3 program, which is on slide 19, the summary of total venous thrombosis events, up to 28 days, in the first column there, you'll see 2 PEs in the active arm and 2 balanced with 2 in placebo. So that, again, just reiterating in a more comprehensive slide, the venous thrombosis events from our 43,000 person study.
Dr. Paling, anything else to add or questions?
I do not. Thank you.
Thank you. Dr. Alt, please go forward.
I want to just ask a quick follow-up question. You had mentioned the Ebola vaccine and the RSV vaccine that used the same vector, and there were no cases of this in those trials. Were there any thrombotic events or thrombocytopenic events, especially in imbalance? In the Ebola vaccine trial, I believe you had a fair number of pregnant and postpartum women, so you definitely had people that had risk factors enrolled in those trials.
Thank you, Dr. Alt, for the question. I'd like to ask my colleague, Dr. Dwogi, from our clinical team to respond to that. We certainly have had no CVST events, as you mentioned, but I'll let Dr. Dwogi respond to your question more broadly.
So I hope you can hear me well. Makaya Dwogi, Head of Clinical Development and Medical Affairs for Vaccines. So it's true we have not seen CVSTs in any of our programs. Ebola and RSV are probably the biggest ones. We have had some cases of DVT and PE. None to our knowledge are associated with thrombocytopenia, and there were clear risk factors, so OCPUs that were considered attributable to the events.
Thank you.
And just if there's just one case of immune thrombocytopenia that we had in the RSV program. We don't know if there is anti-PS4 antibody. I mean, this is relatively new, and this is a case from maybe a year or so ago. We will go back and look to see if there are any stored samples to be able to test. We don't have that information, but that's the only case that we have. and the denominator is for what I'm talking about is about 200,000 people or more that have received at least one dose of an adeno-based vaccine.
Thank you. Dr. Long, please.
Yes, it's a question probably for Dr. Davis about, I didn't quite understand how the epidemiologic studies were done related to the healthcare people that you had under surveillance. I know they had to be in the system for a year, and then did you follow them for a year? And are these basically numbers of cases expected in 100,000 people over 1 year? Because my question would be then, did you do any other sort of tricky analysis? Because the clustering of these cases around the vaccine obviously is very provocative and kind of compelling. So did you estimate the number of cases if you took some random event like the anniversary of the person's birthday and asked in 1 month after some random event, what then would be the number of cases per 100,000 people in 1 month's time?
Thank you for that question, Dr. Long. I'll try to describe the cohort design, and then I'll try to answer your specific question. So yes, it's a kind of classic incidence cohort design where the person had to be observed in the database for a year prior to prove that they didn't have a CVST in their history. So it is looking for new diagnoses of CVST in a 1 year follow-up period. So I hope that answers the first part. The second part, though, your question around picking a random date and then looking out 1 month. I mean, we did look up to a year, and I think if you wanted to generate a person month estimate, I don't have a specific way to answer your question. I don't think.
Maybe the CDC people will address this a little bit, but I'm tempted to want to divide by 12 for the background incidence in a month's time, unless there's some other reason for these other sporadic cases to be clustered, and which would change very much what the dynamic was of, was this in the expected range if they occurred within a month or even 2 months of vaccination. Thank you.
Yeah, when we, maybe I could also add, when we convert this to an expected number, when we do the formal observed to expected analysis, that is what happens. So we do convert it into, if we are generating it for a 28-day risk period, which we would be doing, then we do divide by 12 in order to create the expected number, and that would also be using the age and sex-specific rates.
I see. So in the women of 18 to 34-year age group, where it might be 26 per million, it might actually be 2 per million expected. Right. In a month's time, 28-day time.
We convert it based on, and we apply it to the actual exposure distribution for the vaccinated when we go through that exercise. But to answer your question, I think simplistically, yes, if we want to use these rates to convert them to a expected 28-day observed, expected, yes, you would divide by 12.
And Dr. Long, I do think that some of this will be brought out in future discussions.
Thanks very much. Great, thank you.
Ms. McNally, please.
Thank you. Dr. Marie, I'm the consumer representative, and I am just trying to understand the reporting process on safety events. So can you help me understand how Janssen makes the FDA and CDC aware of serious adverse events that are reported directly to Janssen, and then to what extent Janssen shares the details of those cases with FDA and CDC?
Thank you very much for the question. When patients when subjects are vaccinated in our clinical trial, there is an expedited serious adverse event reporting process via clinical trial process through to the health authorities, Mrs. McNally. In the post-authorization phase, when the vaccine is being given to the public, there are a number of ways in which patient experiences or adverse events can be reported. And when patients receive the vaccine, they're often given a fact sheet, and there is information presented to them on reporting to the FDA, CDC, via VAERS. There is a VSafe program for which I myself signed up, which then sends daily or regular text messages asking for the experience in the post-authorization first few weeks, which then is sent also to theirs. And if any reports of adverse events come directly to the company, we have an expedited reporting process whereby we process those cases and send them immediately to the FDA, to the European Health Authority, and to other global health authorities. So there is a continuing, sustained, rapid reporting of events between the companies and the health authorities in the various jurisdictions. The health authorities then do, for cases of particular interest to them, reach out to the company and also with requests for further information, and we support those again to the deadlines required by the health authorities.
Thank you very much for answering those questions, and your team for answering the questions. We're going to move on to the next presentation now by Dr. Shimabukuro from the CDC regarding the update on thromboembolic events, COVID-19 vaccine safety surveillance. Dr. Shimabukuro.
Hi, this is Tom. Can you hear me okay?
We can.
All right. So as Dr. Romero said, today I'm going to talk about reports of cerebral venous sinus thrombosis with thrombocytopenia after the Janssen COVID-19 vaccine. Next slide. Next slide. So I'll go over some basic background, and then I'll get into specifics on the reports of CVST with thrombocytopenia following the Janssen COVID-19 vaccine, and then I'll summarize the results of our analysis and our plans moving forward. Next slide. Next slide. So you've heard some terms, and I've thrown some terms out there that I think probably deserve some explanation. And these are, for those of us in the medical world, probably familiar with these. Others maybe not so much. So platelets, which are also called thrombocytes, are colorless blood cells that help blood clot. And a normal platelet count is 150,000 to 450,000 per microliter. In the medical world, that's usually shorthanded. We just say 150 to 450. Platelets are important in clotting. They stop bleeding by clumping and forming plugs in blood vessel injuries. Thrombocytopenia, which is a condition in which you have low platelet count, indicating that you have below 150,000 platelets per microliter of blood. Dangerous internal bleeding can occur when your platelet count falls below 10,000 platelets per microliter. I'm usually say below 10. And though rare, severe thrombocytopenia can cause bleeding into the brain, which can be fatal. Next slide. So I think Dr. Bell went over a lot of the detail on the background and kind of set the stage for much of my presentation. And I do repeat a little bit of what Dr. Bell had in her opening presentation. But I want to mention that this issue has been in the public view primarily because of the cases of rare and unusual blood clots with low platelets following the AstraZeneca COVID-19 vaccine. And many of these were cerebral venous sinus thrombosis, and I'll get into some of the specifics about what's happening in the United States. Next slide. And I want to start off with the Janssen COVID-19 vaccine timeline. I just want to say that this is for illustrative purposes. It's not drawn to scale. It's just to kind of outline the timeline of key events and our investigation and some of the timeline for the key decisions that have been made. So on February 27th, Janssen received its emergency use authorization. The following day, on the 28th, ACIP issued an interim recommendation, and then vaccination started on March 2nd. On March 19th is when we received the first CVST report with thrombocytopenia that was reported to the Vaccine Adverse Event Reporting System. These are serious reports. Individuals wind up in the hospital. They meet the regulatory definition for serious, and so that initiates a record collection and an investigation by CDC and FDA. And from the period March 19th through the last confirmed report was on March 8th. We collected these reports. We received these reports. We conducted an expedited record request. We had physicians at CDC and at FDA and in our CISA program do detailed reviews of these cases and accompanying medical records. This investigation is still ongoing, but on April 13th, CDC and FDA recommended a pause in the Janssen vaccine. A HAN was issued, and our investigation continues. Next slide. So this is a screenshot of the CDC HAN that went out yesterday, and in the circled area there, you see some of the key points that CDC will convene an emergency ACIP meeting today to further review these cases and assess the potential implications. FDA is continuing their investigation until the process is complete. CDC and FDA are recommending a pause in the use of the J&J COVID-19 vaccine out of an abundance of caution. The purpose of this health alert is in part to ensure that the healthcare community is aware of the potential of these adverse events and can provide proper management due to the unique treatment required with this type of blood clot. Next slide. So this is a nice 3D figure of the brain. The brain is one of the most, if not the most vascular organ in the body, and as such, it requires substantial venous drainage. And you can see here in these purple vein structures, this is the system that drains the blood from the brain, and these are fairly large veins. It's one thing to note that there is quite a bit of redundancy here. So if there is an issue in one area, other parts of the venous drainage can compensate. So when these cerebral venous sinus thromboses do become symptomatic, these are significant blood clots that are causing these problems. Next slide. So I want to talk a little about epidemiology and risk factors for CVST. And this information is for CVST in general, not necessarily CVST with thrombocytopenia. That's an extremely rare phenomenon, and the epidemiology and the background rates are less well understood just because it's such a rare condition. So what I'm giving you here is for CVST in general, not necessarily with thrombocytopenia. But just CVST in general is a rare condition, occurring in about 0.22 to 1.57 per 100,000 in the population. It's implicated in about 0.5 to 1% of all strokes. It's primarily a disease of younger individuals. The median age is 37. It's pretty rare in older individuals. 8% of patients are greater than 65. The female to male ratio is 3 to 1. Risk factors include genetic or acquired prothrombotic conditions, oral contraceptive use, pregnancy in the postpartum period, malignancy, infection, and then mechanical precipitants, for example, lumbar puncture. Next slide. So the most common presentations are isolated intracranial hypertension syndrome, so headache with or without vomiting, papilledema, visual problems, also focal syndrome like focal deficit seizures or both, and encephalopathy. More rare presentations include cavernous sinus syndrome, subarachnoid hemorrhage, and cranial nerve palsies. Next slide. So now I'm going to get into the data source and case reports. So the data for the case reports that I'm going to present come from the Vaccine Adverse Event Reporting System. I know most of you are familiar with VAERS, but I want to mention VAERS is the nation's early warning system for vaccine safety. It is a spontaneous reporting system or passive reporting system. It depends on astute healthcare providers to recognize and report potential adverse events promptly to VAERS, and it is designed to detect rare and serious adverse events that might indicate a safety problem. It's subject to the limitations of passive surveillance in general, but as you'll see, VAERS performed exactly as intended in this case. It is intended because it has such a wide scope. Pretty much anyone in the population who's eligible to get a vaccine is a potential subject. It's quite robust, and VAERS rapidly detected these rare, unusual thrombotic events in the presence of thrombocytopenia. And I think that this is really a good example of, again, how robust the U.S. vaccine safety monitoring system is, and how in this case, during a large-scale national mass vaccination program, the system worked and VAERS functioned exactly as planned. And I think this is an example of a success story for vaccine safety. Next slide. So I just want to give kind of a high-level overview of what we're seeing for all vaccines. So these are reports of CVST to VAERS after COVID-19 vaccines as of April 12th. And for the Janssen vaccine, we have 6 reports of CVST with thrombocytopenia, so that's a platelet count of less than 150, following 6.86 million doses administered. That comes out to a reporting rate of 0.87 cases per million doses administered, so just under 1 case per million doses administered. By contrast, for the Pfizer-BioNTech vaccine, we have 0 reports after 97.9 million doses administered. And after the Moderna vaccine, we have 3 reports following 84.7 million doses administered. But all 3 of these reports after Moderna had normal platelet counts. And you see the onsets there 2, 6, and 12 days after vaccination. So for the purpose of this specific condition, we don't consider those 3 reports cases because, again, they had normal platelet counts. So for those of us in vaccine safety, we consider this a reporting rate imbalance between the Janssen vaccine and the mRNA vaccines. Next slide. And I'm going to focus on these 6 reports and describing these in more detail in the next slides. Next slide. So before I get into the specifics of these reports, I just want to let you know how they come to our attention. So anyone can report to VAERS. Healthcare providers, patients, parents, caregivers, manufacturers are required to report to VAERS. These reports come in, and if they're classified as serious, according to the regulatory definition for serious, that's death, hospitalization, permanent disability, life-threatening illness, prolongation of hospitalization, congenital anomaly or defect. That information is captured in the VAERS form. And for the Janssen vaccines, folks at CDC and at FDA are doing what is essentially a pre-screening of these series reports. So actually pulling them out and looking at them before they go through the normal processing. And when we began to recognize some of these unusual reports of CVST with thrombocytopenia, and we were looking for them because of the information that was coming out of Europe, we were able to rapidly identify potential cases and do an expedited follow-up to get medical records and follow up with the healthcare facilities. And that was often done by people in the Immunization Safety Office directly reaching out and again, doing an expedited collection of records. So through April 12th, again, we have 6 cases. The median age is 33 years, age range 18 to 48. Median time to symptom onset is 8 days, range 6 to 13 days. I want to say this median time to onset is different than is in the Han. As we continue to gather information, we continue to refine our analysis. In the Han, it was 9 days median onset with a range 6 to 13. It's now 8 days, range 6 to 13. All cases occurred in white females. And you see below an indication of risk factors. There was one case that was taking estrogen and progesterone. There were none actually who were pregnant or postpartum, 3 with obesity, 1 with hypothyroidism, hypertension, 1 with asthma. There were none that had any known coagulation disorders. And I just want to note again, thrombosis usually does not occur in the presence of low platelets. These case presentations are atypical and they're consistent with cases observed after AstraZeneca COVID-19 vaccine. If you remember back to the initial slide when we went over some of the basics of platelets and thrombocytopenia, platelets actually help you clot blood. You need platelets, or they facilitate the clotting of blood. And what we have here is a picture where we have clots forming in large vessels in the presence of low platelets. So it's kind of a paradox here. It's unusual. This usually doesn't happen. And like I said, these case presentations were consistent with cases that were observed after the AstraZeneca COVID-19 vaccine. Next slide. So here are some of the initial and late signs and symptoms of these CVST case patients. They're listed 1 to 6, but they're in no particular order. And I think the important thing to note here is the initial features are largely kind of non-specific symptoms, which at an initial presentation or when a patient starts to become symptomatic may seem kind of mild and not that clinically significant. Things like headaches, lethargy, chills, myalgia. Later features include severe headache, some focal signs, in one case, severe abdominal pain, bruising, swelling in the lower extremities. But if you look again at 5 of these 6 cases, really headache is the initial presenting feature. And so I do think it's important in the setting we are right now that healthcare providers maintain a high index of suspicion for possible CVST and confirm vaccination history, among other things. Next slide. So this slide is in a bit of a different orientation. You have the patients here in columns, but and there's some more detail about the locations of the CVST, intracerebral hemorrhage and other thromboses. The important thing I want to point out here is what I've circled in red at the bottom. So while these were all 6 cases of CVST, the thromboses were not just limited to the cerebral venous drainage system. In 3 of these cases, there were substantial clots and other large vessels in other parts of the body. For example, portal vein and right pulmonary artery. Another individual had bilateral lower extremity venous thromboembolisms, right internal jugular vein, and portal vein. And this is also consistent with what was observed in the cases after the AstraZeneca vaccine in Europe. And it has also caused us to, I think, in the future, cast a little wider net where we're going to be looking for thromboses in the presence of thrombocytopenia. Certainly, most of these cases so far have been CVST, but that we don't think that doesn't mean that the only thing we should be looking for is CVST. We think it's important to look for substantial blood clots in individuals with thrombocytopenia, regardless of whether they're in the CNS or not. Next slide. So this is showing SARS-CoV-2 test results among these patients, and I show the slide just to mention it looks pretty unremarkable. There is some evidence that COVID-19 may place you at risk for thrombotic events. In these individuals, the viral testing was negative, and then the serology was either negative or, and 3 of them was not documented. Next slide. Here are the hematology results among the patients. You can see all of them were thrombocytopenic, and many of them were severely thrombocytopenic, so platelets less than 50. And then for the platelet factor 4 heparin-induced thrombocytopenia, 5 out of the 6, the antibody test results, 5 out of the 6 were positive, and in 1 patient it was not done. Next slide. So treatments, 4 of these patients did get heparin. Non-heparin anticoagulants were given in 5. 3 patients got platelets and 3 got IVIG. There was 1 death, and of the most recent information that we have, 3 remain hospitalized, 2 in intensive care, and 2 were discharged home. Next slide. So here's some early analysis of our observed versus expected, and I want to mention that this is a relatively crude analysis, although I do think it demonstrates, it gives you a good picture of what we're seeing for observed versus expected.
Back in March. We're here.
Looking at calculating individual person time, and I think we'll be able to do a more sophisticated analysis and get some more accurate data on observed versus expected. But in the interim, we wanted to conduct this analysis, and our review of the literature, through the review of the literature, we estimated the annual incidence of CVST of 0.5 to 2 cases per 100,000 population. Now, we assumed a risk period of 5.6% of a calendar year. So the way we did that is we looked at our analytic period, which is basically March 2nd through April 12th, 41 days. We assumed that people contributed person time for roughly half of that time. We didn't know at this point when people got vaccinated or came into the cohort, so we had to make an assumption. We just decided to put that at the midpoint. So we divide that 41 days by 2 to get the person time, and then we divide by 365 to annualize that. Doses administered among women in the 20 to 50-year-old age group, which is where we saw the cases, was just over 1.4 million doses. On this table here, you see is several estimates of reporting rate ratio based on estimated annual incidence. Again, we estimated annual incidence 0.5 to 2 per 100,000. So we're just splitting that out in increments of 0.5. Doing the arithmetic, we're able to calculate our expected cases in women aged 20 to 50 years. So we haven't observed, that's 6. So we're dividing 6 by the expected cases in women aged 20 to 50. And this is a bit of a sensitivity analysis based on what you think the incidence might be. And you can see the reporting ratios for the age group, age sex stratified group at risk ranges anywhere from a low of 3.8 to a high of up to about 15. Next slide. Next slide. So to summarize our findings, CVST is rare but clinically serious and can result in substantial morbidity and mortality. It is not usually associated with thrombocytopenia. This is unusual. The observed cases following Janssen COVID-19 vaccine appear to exceed expected based on background rates of CVST among women aged 20 to 50 years. Actually, can you go back to the previous slide? So I neglected to mention that these expected cases are based on CVST in general. And again, we're looking at an even more unusual form of CVST. This is CVST in the presence of thrombocytopenia. Again, there really isn't enough data that we're comfortable estimating an incidence of this very specific condition in this very specific age and sex group. So these are CVST cases and expected cases in general. So you can almost make an argument that these reporting ratios are basically biased towards lower. Again, because this condition is likely so rare. Next slide. Next slide. I'm sorry about that diversion there. So the observed cases of following Janssen COVID-19 vaccine appear to exceed expected based on background rates in women aged 20 to 50, are at least a threefold or greater. All 6 reports were in women aged 18 to 48, all with thrombocytopenia. There were no obvious patterns of risk factors detected. CVST with thrombocytopenia has not been observed after the 2 authorized mRNA vaccines. There's actually been just over 182 million mRNA COVID-19 vaccine doses administered with no reported cases of this condition to date. The clinical features of Janssen cases are similar to those observed following the AstraZeneca COVID-19 vaccine in Europe. And both Janssen and AstraZeneca vaccines contain replication and competent adenoviral vectors, human for the Janssen and chimpanzee for AstraZeneca. Next slide. So this is straight off the Han, and this is more of a reference slide, but a couple key points for clinicians. We're asking that they maintain a high index of suspicion for symptoms that might represent serious thrombotic events or thrombocytopenia in patients who have recently received the Janssen COVID-19 vaccine. And importantly, do not treat patients with thrombotic events and thrombocytopenia following receipt of Janssen COVID-19 vaccine with heparin unless HIT testing is negative. Next slide. Just a reminder for public health officials and to encourage healthcare providers to report to VAERS, and then some awareness messages for the public. Next slide. So I want to emphasize how important it is to report to VAERS, especially these clinically serious and unexpected adverse events occurring after vaccine. And here you have the information for reporting to VAERS and how you can get help. I want to mention to our healthcare provider partners out there on the front lines, we value We value the work you're doing. We value as partners in vaccine safety. We really view you as our eyes and ears out there to help us detect potential safety problems so we can rapidly assess them and make evidence-based public health decisions. I want to mention that it is important if you do report an adverse event and you are contacted by VAERS or by CDC to please send records as soon as possible. I just want to reassure you that HIPAA permits reporting of protected health information to public health authorities. We are conducting a public health function, and there should be no concerns about reporting medical records to us, so we can do an in-depth review of these and get a handle on what's going on with vaccine safety. Next slide. So our next steps are to continue to enhance monitoring in VAERS and other vaccine safety systems, such as the Vaccine Safety Data Link. I'll just mention that in VSD, we don't have that much Janssen doses administered, only 113,000. We have no cases of CVSD in the risk interval. We'll investigate potential cases through detailed clinical reviews and chart reviews, and we are in the process of assisting FDA to refine the analysis to better quantify risk. Next slide. I wish to acknowledge the following groups for helping with this presentation. Next slide. I'll be happy to take questions.
So thank you again, Dr. Shimabukuro, for another very detailed and easy to understand presentation. We're going to hold questions at this time until after the next presentation. So I'm going to ask Dr. Lee, who is the VAST co-chair and member of the ACIP and the working group for COVID vaccine, to please come forward and to talk about the VAST assessment. Dr. Lee?
Dr. Romero, this is Amanda Cohn. I just wanted to address the persons who may be on the phone and waiting to do the public comment that we are running late for the public comment session. I anticipate that we'll delay the public comment session till about 4 p.m. Sorry, go ahead, Dr. Lee.
4 p.m. That's 4 p.m. Eastern time.
Yes, thank you.
Dr. Lee, please.
Thank you very much. And thanks to Dr. Shimabukuro for that excellent presentation. Next slide. I just wanted to remind folks that the VAST, or the Vaccine Safety Technical Subgroup's role, is to review, evaluate, and interpret the post-authorization, post-approval COVID-19 vaccine safety data as it's coming in, to serve as a central hub for technical subject matter expertise from federal agencies conducting this post-approval safety monitoring, to advise on analyses, interpretation, and data presentation, and to provide updates to the ACIP COVID-19 Vaccines Working Group and the full ACIP on COVID-19 vaccine safety. Next slide. We have met 30 times in total, including 14 meetings pre-authorization and 16 meetings post-authorization or post-recommendation. As a reminder, the mRNA vaccines were recommended for use on December 12th and December 19th, and the first adenovector vaccine was recommended for use in the U.S. on February 28th, with the first doses being shipped on March 2nd to jurisdictions. Next slide. I wanted to just recount the events of the last 48 hours. So VAST met to review the data on CVST on Monday, April 12th. At our last meeting on Monday, the data were presented from VAERS through April 10th, 2021. There were 3 cases at that time following Moderna vaccine without thrombocytopenia, with 83 million doses administered, 0 cases following Pfizer-BioNTech vaccine with 95 million doses administered, and 6 cases following the Janssen vaccine with thrombocytopenia, CVST with thrombocytopenia, with approximately 6 million doses administered. Next slide. VAST noted that the characteristics of the cases following the Janssen vaccine were similar to those following the AstraZeneca vaccine, including evidence of thrombosis with thrombocytopenia, elevated D-dimer, and antibodies to platelet factor 4, where that data were available. These cases were also similar in terms of age group, female predominance, and timing of onset within 2 weeks of vaccine receipt. All Janssen cases occurred in white individuals. We do not yet have any specific information about race ethnicity in the AstraZeneca cases. A couple of other items to note are that the data that VAST reviewed really only focused on the cases, which is really numerator-only data, in order to estimate risks and factors associated with CVST with thrombocytopenia. We really need to also understand the denominator data, which is forthcoming. I also want to emphasize that this is a quickly evolving situation. It has only been 48 hours, and we continue to learn new details even during today's presentation. So, and appreciate everyone's continued vigilance and work in rapidly investigating this potential safety signal. Next slide. After the April 12th meeting, the VAST subgroup discussed these findings in our usual independent fashion and expressed the following based on the review of the data. First, that CVST is a rare but serious potential adverse event following vaccination, that the risk factors are not yet well understood based on these case reports. VAST members expressed their concern about delayed recognition of this new entity. CVST with thrombocytopenia is fairly unusual, and VAST felt strongly that early recognition was critical for timely and appropriate management, including the use of IVIG and anticoagulation with non-heparin-based therapies. Next slide. Vaccine safety is paramount to all of us. In this situation, we are really appreciative that our global safety monitoring efforts and the VAERS team enabled the CDC and FDA to rapidly detect these adverse events. VAST felt that information about this potential life-threatening adverse event should be promptly provided to clinicians in order to enhance early recognition and appropriate treatment of persons who develop thrombosis with thrombocytopenia following vaccination. Next slide. And on the 12th, there was also discussion that further evaluation of the benefit-risk balance of using the Janssen vaccine in specific subgroups would be warranted. Other vaccines are currently available for use in the U.S. for the prevention of COVID-19, and that timely and transparent communication with healthcare providers and the public is crucial to maintain confidence in the vaccination program. Next slide. And within 24 hours of that discussion, our colleagues at CDC and FDA communicated these findings to providers and to the public, as you heard. Next slide. Going forward, VAST plans to focus on enhanced case identification, including for those patients who are recently vaccinated with the Janssen vaccine. We continue to encourage patients to enroll in BSafe, and for providers and patients to report to VAERS, as Dr. Shimabukuro mentioned. This is incredibly helpful for all of us, and we hope to continue to support vaccine safety monitoring. We also will proceed with our typical signal investigation process that includes 3 phases. The first phase is signal identification, which has already happened here. The second phase is signal refinement, which includes a series of steps to evaluate the magnitude and clinical significance of a suspected association. And the third phase is signal evaluation, which often consists of formal epidemiologic analyses to more definitively establish or refute causality. Next slide. The signal refinement phase for CVST with thrombocytopenia will include a review of findings in other vaccine safety surveillance systems and an assessment of the risk of developing CVST in various subgroups in order to inform risk mitigation strategies and support decision-making. VAST will continue to review all safety data from the U.S. COVID-19 vaccination program and any data that are also made available to us for review outside the U.S. And we will continue to update the ACIP COVID-19 Vaccines Work Group, the ACIP Secretariat, and the full ACIP on a regular basis. Next slide. Just wanted to take a moment to thank our VAST members for their hard work and continued vigilance over the past 4 months, and our federal colleagues, and especially CDC and FDA with this particular signal investigation, and for their continued dedication to vaccine safety. And I also just wanted to thank our Janssen colleagues for their collaboration on ensuring that we maintain trust and confidence in vaccines and in public health. And with that, I'm happy to conclude and turn it back to you, Dr. Romero.
Thank you, Dr. Lee. So what we'll do at this point is open up the last presentation for questions. And if necessary, we will break so that the public comment session will go forward and then come back if there are still more questions. So let's start with the voting members, please. Dr. Alt, I see your hand is up.
Dr. Romero.
Yes, I had a question.
Yes, Dr. Cohen.
I also just want to let you know that there's one more presentation that we have before public comment.
I'm sorry.
That's
yes.
okay.
You are correct. So let's take some comments, the questions now, please. Go ahead.
This is a question for Dr. Lee about slide number 6. It occurred to me while I was looking at that slide that we don't usually, ACIP doesn't interact with emergency room physicians, hematologists, inpatient hospitalists, and a bunch of other groups that might, maybe it was a different slide number. You were, we're not interacting with people who are going to have to make these decisions. What are we doing to get the word out to groups that might be in a position where they need to do timely management and that type of thing?
Happy to cede my time to our CDC colleagues, but we really, look to our both CDC and our partner organizations around the table, many of whom communicate with our provider communities, as well as our public health colleagues who have also put out state HANs to ensure that this information expeditiously gets to all individuals. And also, I'm hoping that this open meeting will help stimulate the necessary attention to ensure that we are providing timely diagnosis and management of these cases.
And Dr. Alt, this is Amanda. I just will add that we do have a COCA call planned to do some additional outreach to clinical providers for tomorrow. And we will continue to resend out an alert in all of our many emergency response ways to emergency room providers as well as primary care doctors and other healthcare providers about what to look for as well as how to immediately manage any potential cases.
Thank you.
Ms. Bata.
Thank you, Dr. Romero. I don't know if you can share this data, Dr. Shimabukuro, but was the death, was that associated with heparin treatment? And can we attribute that to heparin treatment? And then not working in a hospital or in the clinic setting, I'm wondering how available is the PS4 ELISA test for antibodies?
Is Dr. Broder on the call? Did she may be able to give? Yeah, can you take that, or do you know the answer to that first question?
Well, the first question, at this point, we're just trying to, this is Karen Broder from the Clinical Immunization Safety Assessment Project. Good afternoon. And I work in the Immunization Safety Office. For the case unfortunate case that died, we're trying to learn about the case. We really are not in a situation where we're looking specifically epi cause of death, and we defer that to the jurisdictions. I will say that in reviewing the cases in general, it does appear that a number of cases were initially treated with heparin, and that is one of the reasons why the Health Alert Network and message communication has gone out to ensure that people are more aware of this condition, and that heparin is not to be used unless the HIT testing is negative. Thank you. With respect to the second question, to the best of my knowledge, this HIT testing is an available test in hospitals, but I am not aware of the nature of the availability in all the regions. And I would, there may be experts on the call that could better address that question. Thank you.
Thank you.
Dr. Bernstein, please.
Thank you. I had a question for Dr. Shimabukuro and one for Dr. Lee. First, Dr. Shimabukuro, fabulous presentation as always. Can you go to slides 20 and 21, please? Next slide, sorry. So this slide under treatment, it says that 4 patients, 4 of the 6 received heparin. And then if you go back to the previous slide, there's 5 patients were antibody test result positive. Does that make sense, or am I misinterpreting? Shouldn't 5 of them have been treated with heparin to have a heparin-induced thrombocytopenia?
That's not what induced.
Yeah, I think those are separate. I think that I think that this phenomenon occurs as prior to them actually getting, in this case at least, prior to them getting treated with heparin. I think I would ask Karen or Dr. Broder if she may have a better idea of kind of the mechanism or the pathophysiology of this condition.
Yeah, Tom, this is Karen again. I would certainly defer to experts, but it is my understanding that the use of heparin is not going to trigger a test positive immediately, and that the idea, the thought is that this may be a similar mechanism to what Dr. Bell described earlier, where this test is positive due to the effects of the vaccine, and that is the giving of heparin may just exaggerate the situation and make it worse. Certainly would defer to other colleagues with additional expertise in the topic, potentially on the call. Thank you.
Thanks. And then the question, Tom, about since we're trying to study children and de-escalating it by age, I was wondering do we have background rates for CVST in children? Because we're doing immunobridging, but I don't know about immunosafety or whatever.
I believe we do have background rates. I don't have them in my presentation, and I would have to get back to you on some of the specifics of what these rates are by age and by sex.
Okay, that would be interesting, since we do want to involve children vaccinated as well. And then for Dr. Lee, if there's 106 AstraZeneca cases so far and 6 Johnson & Johnson, are the number of cases between these 2 viral vector vaccines attributable to the overall number of doses that have been administered? Or is there a difference between chimp and human adeno?
I think many of those questions are ones that we, so number 1 about mechanism of action, and number 2, making sure we have clarity on the denominators in terms of, who's received these vaccines. As we know, the allocation strategies in our country and in other countries may mean that the individuals who are exposed to these vaccines denominators might differ. And so that's where I think that additional information will be helpful. I just did also want to emphasize on the earlier point that if somebody has an anti-PF4 antibody, I think the concern being that heparin would not be an appropriate treatment for use, and that other anticoagulation therapies would be indicated if they had the presence of this particular antibody, and that it's not necessarily the exposure to heparin during this admission that's creating that positivity. It's sort of an indicator or a marker of potential an immune response that is facilitating this thrombocytopenia and associated thrombosis. I think that is the question. The main point to get across being that that diagnostic test is helpful to know whether or not it's safe to use heparin.
This is Tom. That was much more elegantly stated than my response. So yes, I completely agree with Dr. Lee on that.
So that's using it as a screening is so critically important. Thank you.
Okay, so I see that Dr. Dushin has been patiently keeping his hand raised, and Dr. Dries also has raised her hand. So what we're going to do now is take Dr. Long's question, then we're going to proceed to Dr. Oliver's presentation, and then return to questions if time allots, or go to the public comment and then return to questions. I'm sorry that's so convoluted, but we're not rushing this. We want to give everybody a chance. So Dr. Long, please go forward.
Yes, the first, it's for Dr. Shimabukuro. The first would be the thought that the thrombocytopenia is causing the thrombosis is not likely the horse in the cart correctly, but is a manifestation either of destruction of platelets in the thrombosis event, or microvasculopathy, or platelets that have antibody on them are very sticky, et cetera. So there are a lot of potential things, but I don't think that we want people to think that the thrombocytopenia is causing the clots. It's a risk for bleeding associated with the clots. But the part about the cerebral venous thrombosis is seemingly special to me for this vaccine. We see lots and lots of people who get lots and lots of clots who have platelet antibodies, who have atypical hemolytic uremic syndrome, thrombotic thrombocytopenia purpura, and it's not cerebral venous thrombosis. So I think could be another special thing about this. My specific question for you is twofold. One is, with the number of doses administered so far of the Janssen product, do we have time to have the reporting of adverse events from the majority or almost all of those doses? It seems unlikely. That we may learn more. It's likely that we may learn more in the next 2 or 4 weeks, as well as people recognizing they may have a case of this and didn't really put it together with the vaccine. That's the first question. Do we know the whole story? Or during this pause, is there still more information we're going to learn? And the second is the inference of white women might infer that people of color, women of color, are not at risk. And I wonder if we know anything about the vaccine distribution to white women versus non-white women.
Tom, this is Sarah Oliver. I'll let you know. I have both of those points in my presentation, if that saves you from
I should have known.
answering the question.
Thank you.
Sure.
So,
Okay. Is there anything else, Dr. Long? Okay, so what we're going to do next then, Dr. Cohn, did I hear your voice a minute ago?
I was just going to say I was going to recommend we do Dr. Oliver's presentation, then come back to Dr. Duchenne. Yeah.
Exactly, Dr. Cohn. So please, Dr. Oliver, who is the lead for the COVID-19 work group, she's going to present work group interpretation. Dr. Oliver, please, and then we will come back to Dr. Dushin and Dries. Doctors.
Thank you so much, and good afternoon. Next slide. So in this presentation, we're going to walk through the overall risk-benefit balance for the use of the Janssen COVID-19 vaccine that's been discussed by the work group. This includes a review of the cerebral venous sinus thrombosis, or CVST cases, the risk of COVID disease by age and sex, COVID-19 vaccines administered by age, Janssen vaccine doses administered to date, and projected supply of COVID-19 vaccines in the U.S. Then, the work group discussed policy options for updated recommendations for use of the Janssen vaccine, and we'll walk through those as well. Next slide. So the work group reviewed 6 cases of CVST reported to VAERS, all 6 among women 18 to 48 years of age, with the interval from vaccine receipt to symptom onset ranging from 6 to 13 days. And these cases have been described in detail previously. We also discussed the case of CVST reported in the Janssen phase 3 trial in a 25-year-old male. The Janssen presentation described these case details as well, but the symptoms developed 9 days after vaccination, and on day 21 post-vaccine was diagnosed with CVST and ultimately found to be anti-platelet factor 4 antibody positive. Next slide. So next we'll walk through overall COVID epi. The exact risk factors for CVST are unknown, so it's difficult to highlight the epi among the specific population at risk for this CVST with thrombocytopenia, but we'll discuss epi by several possible factors that could be associated with these cases. First, the slide shows COVID cases and deaths by sex. Overall, females represent a slightly higher proportion of overall cases on the left in blue, but a slightly smaller proportion of COVID deaths in red on the right. Next slide. So this slide shows COVID cases by age group. The bars in blue show percent of cases by age. You can see that the younger age group, this 18 to 29 years, actually represents a higher proportion of COVID cases relative to the percent of the US population shown in gray. Next slide. This slide shows COVID-associated hospitalizations by age and throughout the pandemic. You can see that the oldest population in dark blue on the bottom has represented a larger proportion of hospitalizations throughout the year compared to the younger populations. Next slide. And finally, COVID-19 deaths by age. I think we're all well aware now, but the oldest age population, shown here on the bottom, represents a substantial proportion of deaths from COVID relative to the younger population. Next slide. So next we'll move to COVID vaccination coverage by age. You can see that here among the oldest population, those 65 and older, nearly 80% of the population has received at least one dose. 40 to 50% of adults 40 to 64 years of age have received at least one dose. And 25 to 30% of those 18 to 39 years of age have received at least one dose of a COVID vaccine. So this highlights the proportion of the population who is yet to be vaccinated with any of our COVID-19 vaccines, and the population to be most impacted by future recommendations. Next slide. This shows the number of doses administered to adults by age group, showing millions of adults who are fully vaccinated and partially vaccinated by age group, fully vaccinated in blue and partially vaccinated in red. Next slide. So next, specifically moving to the Janssen doses administered by date, there have been over 7.2 million doses of the Janssen vaccine. If we limit to the population 18 to 50 years of, to the female population 18 to 15 years of age, we can see that there have been approximately 1.5 million doses to date. Next slide. Then to get to the question that was asked earlier, this is breaking down Janssen vaccines administered by various populations. You can see from male to female, there's been a relatively even split. By age, given the time that this vaccine rolled out, only 18% of doses were administered to those 65 years of age and older. The majority of doses have been given to adults 18 to 50 or 50 to 64 years of age. And then race and ethnicity is listed here as well. There is a proportion where we don't have race and ethnicity available, but of doses where we do know, you can see around 60% were administered to white non-Hispanic individuals, and the remaining proportion distributed is shown here. Next slide. So there was another way that the work group thought through these doses administered. So from currently available data, these thrombocytopenic thrombotic events developed 6 to 13 days after vaccine receipt. We know that there are around 7.2 million doses administered. So if we think through doses from the beginning of the program, the Janssen program in early March through March 30th, there are around 3.4 million doses, or around 48% of doses administered. If we think through a risk window of up to 2 weeks after doses were administered, it's likely that if these vaccine recipients were to develop thrombocytopenic thrombotic events post-vaccine, then they would have likely already occurred. However, if we think through doses administered within the last 2 weeks, shown here on the right, from March 30th to April 13th, 3.7 million doses have been administered, or 52% of doses have been given within the last 2 weeks. Therefore, the thrombocytopenic thrombotic events post-vaccine may still occur after these doses, as these individuals would still remain within their risk window. Next slide. So next, moving to overall COVID-19 vaccine supply considerations. For mRNA vaccines, we expect somewhere around 14 million first doses of Pfizer and Moderna vaccines each week, hopefully without any substantial interruptions expected. For the Janssen vaccines, to date, Janssen vaccine comprises less than 5% of the vaccines administered, although I will note that this program started in March compared to December with the mRNA vaccines. There are approximately 13 million doses of Janssen vaccines currently available, around 3.6 million doses that would be available to order, and around 9.2 million doses that are currently available at administration sites. In addition, there may be an additional 11 million doses by the end of April. We did want to highlight that while doses for the Janssen vaccine may be less than for the mRNA vaccines overall, we highlight that the Janssen vaccine has occasionally been used in populations that may be difficult to reach with mRNA vaccines that would require freezer temperatures or 2 doses. Next slide. So then, trying to summarize what we know so far, thrombocytopenic thrombotic events have occurred after the AstraZeneca vaccine. In the US, 6 cases of CVST and thrombocytopenia have been reported after authorization and receipt of the Janssen vaccine. No cases of CVST with thrombocytopenia have been reported after receipt of either Pfizer or Moderna vaccines. These CVST cases have primarily occurred in younger adults and in females. CVST can be clinically devastating or fatal. Then we wanted to highlight that in the US, alternative COVID-19 vaccines, the mRNA vaccines, are available. And based on current projections, supply of both vaccines are expected to be relatively stable in the near future. Therefore, the decision isn't necessarily receipt of a Janssen vaccine versus remaining at risk of COVID. The decision may be receipt of a Janssen vaccine versus receipt of another mRNA vaccine. Next slide. We also wanted to highlight what we do not know. Currently, we don't know the true background incidence of CVST with thrombocytopenia. We don't know the specific risk factors for these thrombocytopenic thrombotic events. We don't know the incidence of other thrombotic cases with thrombocytopenia, so non-CVST, after the Janssen vaccine. We don't know the ability to compare or generalize the thrombotic cases seen after the AstraZeneca vaccine to the Janssen vaccine cases. And finally, we don't know the true incidence of thrombocytopenic events, thrombotic events after Janssen vaccine, as there may be more cases identified in the coming days to weeks. Next slide. So now we'll move to the policy options for the use of the Janssen vaccine. Next slide. The work group had several discussion points overall. First, while the reported CVST cases are rare, once limited to doses administered to the age and sex of CVST cases, the observed cases exceed expected cases. Given the timing of doses administered, additional cases may be identified over the next 1 to 2 weeks. And then finally, an emphasis that robust safety surveillance is critical. The fact that we're having these discussions so quickly after the cases demonstrate that signal detection and evaluation of cases occurred as planned, moving to public discussion of these safety issues and policy implications as soon as possible. Next slide. So there's a spectrum of policy options available for the Janssen vaccine. ACIP could decide that the risks outweigh the benefits and vote to not recommend use of the Janssen vaccine due to these safety concerns. ACIP could also decide that the benefits outweigh the risks overall and recommend use of the vaccine in all adults 18 years of age and older. Next slide. But the work group also discussed something in the middle of the spectrum as well, recommending use of the Janssen vaccine in some populations with age or gender-specific recommendations, such as adults 50 years of age and older or males only. Next slide. So I'm going to walk through some of the work group discussions for each of these points. First, for sex or gender-based recommendations, the work group was concerned that these would be quite difficult to implement and was not terribly supportive of this policy option. Next, for age-based recommendations, there was concern that we may not have sufficient data at this time to inform a specific age cutoff. However, the work group acknowledged that many countries in Europe have used an age-based approach for the AstraZeneca vaccine recommendations. And overall, it would allow additional options, a choice of an mRNA or an advector vaccine in an older population that's at risk for COVID. Next slide. So then the work group also discussed the possibility of extending the pause while awaiting for additional information. This could potentially allow for a more informed, specific recommendations for the Janssen vaccine. We could evaluate the risk by age and inform possible age-based recommendation. It would also allow for further assessment to see if the thrombocytopenic thrombotic risk extends beyond CVST cases. However, extension of the pause could have broad consequences. Individuals may want to receive the Janssen vaccine. In addition, a pause could have global implications, such as pausing clinical trials or limiting the ability of the Janssen vaccine in other countries with more limited vaccine supply. The work group had a full discussion around these policy options yesterday and favored extending the pause for a limited period of time while awaiting additional information. Next slide. So to move to specific recommendations, at the top here is the previous Janssen vote and recommendation for reference. Then we're proposing 2 questions to ACIP to discuss. Does ACIP have enough information to make interim age or risk factor-based recommendations for the use of the Janssen vaccine? We want to acknowledge that these recommendations would be interim and could be updated as needed. And then what recommendation does ACIP feel is appropriate today, given the current available information for use of the Janssen vaccine? The pause issued by FDA and CDC was only until ACIP discussed today. There are 2 things before we open up for discussion. First, I need to thank the many people who helped pull this information for the work group yesterday and the meeting today in just a matter of hours. It is absolutely a team effort. And then I want to toss to Dr. Fink from FDA to present FDA's thoughts on this before we open up to ACIP member discussions. Dr. Fink.
Thank you, Dr. Oliver. On behalf of FDA, I would sincerely like to thank the ACIP and the COVID vaccines work group for today's informative presentations and what I'm sure will be a thoughtful discussion of this safety signal and considerations for a path forward. As we work to better understand the nature of this signal, including potential mechanisms and risk factors, FDA will continue to collaborate closely with CDC to collect and evaluate information as it becomes available, and will also continue to collaborate closely with our regulatory and public health counterparts outside the U.S. to leverage their experience with the similar safety signal observed with the AstraZeneca vaccine. The pause recommended yesterday morning out of an abundance of caution has raised national awareness of the safety concern and has provided time and opportunity to carefully and collectively evaluate the information at hand and to formulate questions that remain to be addressed. In FDA's ongoing assessment of these rare but serious thromboembolic events with thrombocytopenia, our current thinking is that this risk could be managed by inclusion of warning statements in the EUA fact sheets along with coordinated communications from FDA, CDC, and others to inform healthcare providers and vaccine recipients of the potential risk and symptoms that should warrant medical evaluation, as well as advice to ensure proper diagnosis and management of the condition and reporting of any additional cases. With such information available, FDA appreciates that individuals, in consultation with their healthcare providers or vaccination providers, may arrive at a conclusion of favorable benefit risk after taking into account demographic factors, risk of exposure to SARS-CoV-2 and severe outcomes from COVID-19, and access to other authorized COVID vaccines. Consequently, this risk management approach could be considered to allow for further assessment of the safety signal concurrent with resuming use of the Janssen COVID vaccine in individuals or populations for whom the benefits of the vaccine continue to outweigh the risk. Thank you very much.
Thank you for those comments. Thank you, Dr. Oliver, for another outstanding presentation. Dr. Cohen, a question for you. The public comment session had been delayed, and you mentioned that we were going to try to do it at 4 p.m. Eastern time. Do you want to proceed to the public comment session, or do you want to take questions at this moment for Dr. Oliver's presentation?
Dr. Romero, could we wait, take questions till 4:10 and then take a 5-minute break and do public comment at 4:15?
So questions until 4:10, then a break, and then comment.
And then discussion after.
Very good. So great. Then these presentations are open for discussion. Let me go back to Dr. Dushan to see if he wants to ask his question, followed by Dr. Dries.
Thank you, Dr. Romero. I still remember my question. It's for Dr. Shimabukuro, and I'm curious if it's possible to have an estimate, any sort of ballpark estimate, of the time frame that in which we could learn more about the potential safety signal from non-CVST thromboses associated with low platelets, to get a better picture of what a potential syndrome might be that's associated with this vaccine. And then secondly, is there any role for VSafe in telling us anything about this potential issue? Thank you.
Dr. Dushan, can you repeat the first part of your first question again?
Yes. If there's any way to estimate, a ballpark time frame that would allow us to understand whether there's a safety signal associated with non-CVST thrombotic disease with low platelets.
That may be difficult to say because it's such a rare condition in general. We are reviewing every potential case that comes in, and one of the things we're looking for in the report and in the medical records is low platelets. So, we are able to identify cases with thrombocytopenia and cases without thrombocytopenia. We also have other adverse events of special interest that I think we're going to look at a little differently, like PE or pulmonary embolism and venothrombus embolism. So I do think that now that we're aware of this unusual condition of thrombotic events in the presence of thrombocytopenia, we are going to reevaluate how we do our surveillance to try to get a better idea of what's happening with these reports. But I'm not sure if I can put a specific timeline on that at this point.
Okay, thank you, Tom. Anything we can learn from VSafe?
I think the main benefit from VSafe may be to get these reports into VAERS. I will say for these specific reports, these individuals are quite ill and in the hospital and in the ICU. So probably they're not reporting for themselves. They're not able to actually submit a report. And the initial presenting symptoms like headache and fatigue are quite common and maybe less useful. I think for a rare serious condition like this, the vaccine adverse event reporting system, as demonstrated, is the system that's going to be able to rapidly detect and evaluate these initial reports. And I just want to emphasize again our partnership with healthcare providers out there seeing patients, recognizing potential adverse events and reporting them in, and then working with us to access medical records so we can further evaluate these rare and serious adverse events. But as Dr. Oliver said, and as I said, I think this is a good example of the system working, a good example of how robust the system is, and a good example of how the U.S. vaccine safety system is able to rapidly detect rare serious events and assess them.
Thank you.
Dr. Dries, do you want to ask your question?
Yes, thank you. I was actually just trying to reply to a couple of the questions that were raised during the earlier discussion. The first was the question about the communication of the information in the HAN. And I just wanted to endorse what Dr. Lee had replied, which is that the distribution system for the HAN alerts is actually, pretty robust. And we certainly have communicated that information out, to the emergency department, hematologists, et cetera. And honestly, even before the HAN was released, we were already getting questions from PCPs, from patients, from the emergency department. And so we do really appreciate how quickly the HAN was released and the level of clinical detail and guidance that was in the HAN. The second question was around the availability of the testing, the heparin-induced antibody testing. And that was really one of my first tasks when I got the HAN, was to figure out what is this test and do we have it? And just, to use my own institution as an example, we are a large, clinical laboratory that's, I think, fairly sophisticated, but we do not have that test on site. We use it, we send it out with a minimum of a 48-hour turnaround time. So I would anticipate that the majority of hospitals in the country would have to send out to get availability of that test. Thank you.
Can I ask a question to follow up that you may not know, but are reference laboratories able to scale up testing for this if there's a surge in requests for this test?
Yeah, I certainly don't have the answer to that. I don't know how many different reference laboratories are typically used by community hospitals, and it is a fairly specialized test, so I would imagine the demand is going to increase quickly.
Thank you for that information. Let's go to Dr. Kimberlin. Dr. Kimberlin, please.
Yes, David Kimberlin, AAP Red Book. This is a question for Dr. Shimabukuro. On the first of your summary slides, it was slide 24 in your slide set, there's a key summary, I think, at least for me, that the observed rate was threefold or greater the expected rate. Can you point me to where that is in your presentation? I want to make sure I understand exactly what it is we're looking at.
If you can go to slide 22. So this is an observed versus expected. So I mean, the observed in this case is 6. We've observed 6 cases in the analytic period, and then we do the calculations above to get to how many expected cases, how many cases we would expect to see in women 20 to 50 years old in the same analytic period. And so this is basically 6 divided by 1.58 comes out to 3.8, and we do this for different estimated annual incidences because there's a range of incidences. That's what you're seeing there, at least 3, possibly up to 15.
So the calculated observed is the far right column, the expected is the middle column.
No, the observed is 6. We have 6 cases in the analytic period. I guess I should have added in a column. So the observed is 6 for everything. The expected varies based on the estimated annual incidence. And so it's basically 6 divided by 1.58 equals 3.8. 6 divided by 1.18 equals 5.1. I see where that's confusing. We should have put in the observed is just 6 because that's what we've observed.
I understand. Thank you very much.
Thank you. Dr. Shaw.
Thank you, Dr. Romero. Good afternoon, everyone. Nirav Shah from ASTO and from the state of Maine CDC. Dr. Shimabukuro, actually, my question pertains to this slide as well. Recognizing that you and your colleagues at FDA are refining this analysis, I did have a question in connection with your choice of denominator here. I note, and as noted on the third bullet, you restricted the denominator to doses administered among women aged 20 to 50. I was curious about that, recognizing that epidemiologists often disagree on denominator choices. It seemed plausible that your denominator could have been all recipients of the vaccine, irrespective of their age, given that in the clinical trials, there was one male with CVST, and then to the extent the mechanism of action with AstraZeneca in Europe is plausibly similar, there have been men there that were also affected. And including that and doubling the denominator would, of course, greatly affect the ratios that we see here. How should we think about that?
I don't disagree with you, but we had observed all cases were in women aged 18 to 48 years old. So, I mean, that is because it appeared to be concentrated in that age group. We decided that the best analysis would be to look at that denominator. But certainly, I hear what you're saying, and I think for future analyses, we can certainly expand our analysis.
Thank you.
Sorry, I was still on mute. We still have hands up from Dr. Sanchez and Dr. Goldman. I will give you an opportunity to speak in a few minutes. What we're going to do now is pause for the public comment session, and then we'll return. So let's take a short break, 5 to 7 minutes while we get set up, and then we'll come back. I have 13 after the hour, so we'll come back at 20 after the hour and begin our public comment. Thank you. We will resume in 1 minute. Dr. Cohen, may we proceed to the public comment session?
Yes, that would be great.
Thank you very much. So at the onset of this session, I'd like to welcome and thank the public speakers for addressing the committee today. We take very seriously what you tell us and look forward to your presentations. To all speakers today, I want to mention that we have a limited time for public comment. And in order to make it through all the speakers, it is extremely important that each of the speaker limits his or her remarks to the 3 minutes allotted to them. We will be displaying the time on a timer that will cycle through various colors and then inform you of when your time is up. All speakers today have submitted a request in advance of the meeting, and the final list of public commenters was determined via lottery. Again, to the commenters, I want to say that as you reach the end of your allotted time, I will thank you with the following phrase. Thank you for your comment. Your time has expired. If you extend 15 seconds past that time, I will say the following. As a courtesy to other speakers, we ask that you conclude your comment. And if you extend to 30 seconds past your allotted time, I will ask that your microphone be cut and state your comment time has expired. Thank you very much. So again, thank you for the public commenters, and we'll begin with our first commenter, Mr. Del Bigtree. Please come to the microphone. Please state your name and any affiliations that you have. Mr. Bigtree.
Dr. Romero, I'm not sure he's on yet. Would you like to skip him and go to the second person?
Thank you, Stephanie. Yes, so next we'll go on to Dr. Richard Younghans, and excuse me if I mispronounced your name.
You got
Dr.
it.
Younghans.
Yeah, my name is Dr. Richard Younghans. I'm an immunotherapist, hematologist, oncologist, trained with Thomas Waldman at the NCI, and I'm associate professor at Boston University School of Medicine and president of IT Bio LLC, an immunotherapy company in Cambridge, startup, I should say. I have a technical comment about the antiplatelet antibodies. If I have time at the end, I'll allude to, but I want to jump into what I consider the elephant in the room. That is prior infectees, people who've been infected previously. I contend have a superior immunity to any conferred by these very good vaccines even. And if I'm right, then we're subjecting patients to risk unnecessarily, however small these risks are, which are being addressed today. It also wastes a drug that could have been used to save other people's lives already who waited in line for those who didn't need it. And so the policies I would like to see changed would be to accord infectees the same status as vaccinated officially by CDC, which is an example around the world. This would be for so-called immunity passports, jobs, travel, etc. Exempt them from vaccination, except as vaccination requirements that some jobs have put in place. And any prior positive test by PCR, antigen, or antibody would be accepted. Antibody waning doesn't concern me because neutralizing antibodies are not as judged by this assay as proven in the initial Chinese study that focused on total antibody waning, but it was the wrong focus. Neutralizing antibodies predicted to persist for years. And antibodies aren't critical anyway. T cells are the main bulwark of the therapy, of the immunity. This is seen in X-linked A-gamma globulinemia, where patients don't get sick from bad viral infections, they get sick from bacterial infections. Proof that infection is better is quickly available. Look at the Pfizer vaccine study, 20,000 patients per arm, 160 in control arm got infected, 8 in the vaccine arm got infected. If you compare that 20,000 to 20 million patients who've recovered, documented to recover from COVID, that would predict 8,000 second infections, and it's been hard for people to find even a dozen such cases. CDC estimates a 4.6 to 1 ratio of people infected to those who've actually tested positive. And that would mean 138 million people have been infected out of 210 million.
Thank you for your comment. Your time has expired.
Okay, I'd like to say that I'll be posting this material.
Thank you very much.
Thank you.
Our next commenter will be Mr. Del Bigtree. Mr. Bigtree, please state your affiliation and proper pronunciation of your name if I mispronounced it.
My name is Del Bigtree. I am the CEO of the Informed Consent Action Network. I'm the host of the Internet Talk Show, The High Wire. I am formerly a producer of the CBS talk show, The Doctors, where I won an Emmy Award celebrating the best that science and medicine has to offer. I have been attending the meetings at the Advisory Committee on Immunization Practices for over 3 years now, and I've spoken many, many times during public comments, and I have done several now of these over the computer. And I have been saying and trying to make the same point for some time now. You at the CDC and at the Advisory Committee need to start taking much more seriously the visibility of the work that you're doing and the promotion and the PR around it. I have been warning you that you cannot continue to keep promoting products like vaccines made by Johnson & Johnson that have not been properly tested for long-term issues or even short-term issues in the clinical trials. We are talking about a company that has paid out billions of dollars for lying about safety on talcum powder. They always knew it had asbestos. They lied about the OxyContin epidemic, and yet you at the Advisory Committee and at the CDC now find yourself in an incredible situation and something that I've been warning you about. Confidence in this vaccine program, and now the CDC is in grave, grave danger. We now have a vaccine that is just like the AstraZeneca vaccine in Europe, and I am honestly questioning the CDC. Are you going to make the same mistake that the EMA in Europe made and try to cover this up and say, oh, it's going to be just fine, only to have to retract that a couple of weeks later? And now we have nations like Denmark withdrawing the AstraZeneca vaccine because their own science shows that this issue is happening in 1 in 40,000 people. What will be the plan? The CDC, if it wants to hold on to any credibility right now, is, and not risk not only a loss of confidence in our healthcare system, in the CDC, but maybe in science as we know it. I urge you, please, withdraw Johnson & Johnson completely. Europe is now overrun. The UK, their hospitals are overrun by people that are panicking, even from mild symptoms. Our hospitals can't afford this. This mistake is only going to get worse and worse. We have 2 other vaccine options. Please do the CDC a favor, do this nation a favor, and lead by erring on the side of caution for the citizens and not the pharmaceutical industry, and pull Johnson & Johnson immediately, or we could seriously see the destruction of confidence in all vaccine programs and science as we know it. This is what is now sitting in your hands. Thank you. I hope this time you will finally hear my plea.
Thank you for your comments. Our next commenter is Ms. Marla Dalton. Ms. Dalton, please, your name and affiliation.
Thank you and good afternoon. I am Marla Dalton, Executive Director and CEO of the National Foundation for Infectious Diseases, or NFID. On behalf of NFID, as a long-standing partner of CDC, we appreciate the valuable work of ACIP and the robust U.S. vaccine safety surveillance systems in place. Monitoring the safety of vaccines is an ongoing process, and the decision by FDA and CDC to review reports of a rare blood clotting condition among some recipients of COVID-19 vaccines demonstrates the strong U.S. commitment to vaccine safety. To date, there have been 6 reported cases of blood clotting among the approximately 7 million doses of the Johnson Johnson COVID-19 vaccine administered in the U.S., clearly demonstrating the sensitivity of the vaccine safety system in place. The fact that public health officials have paused administration of the vaccine to investigate these reports is reassuring to all of us who are committed to vaccine safety. And we at NFID stand ready to help communicate the results of the data analysis and any implications for public policy. The actions taken by CDC and FDA also illustrate some of the core principles of communicating about COVID-19, which are outlined in a new NFID report, COVID-19 Communications, Promoting Prevention Measures and Vaccine Confidence. The report, which was developed with input from more than 50 leading organizations and multidisciplinary experts, is now available on the NFID website at nfid.org. As the science and knowledge around COVID-19 continues to evolve, being open and transparent about what we know and what we do not yet know helps all to manage expectations and reduce anxiety and confusion about vaccines and other COVID-19 prevention measures. The work of ACIP in guiding U.S. immunization policy and overseeing vaccine safety is vital to protecting public health. On behalf of NFID, thank you all for your dedicated service.
Thank you for your comments. That ends our public comment session for this meeting. Dr. Cohen, do we want to proceed or give the group another 5-minute break?
I think if you're okay with that, I think we can go ahead and proceed.
Very good.
We can both continue to ask questions and then also maybe bring up the last slide that Dr. Oliver shared so we can remind the committee what the questions that we're posing to ACIP to discuss are. Thanks.
Correct. Let me also return to Dr. Sanchez and Dr. Goldman, who have been waiting patiently to ask their questions. Dr. Sanchez, please go ahead and ask your question.
Thank you, Jose. It's more of a comment. I think, first of all, we do have a positive message that we do have 2 vaccines currently available in the United States that have not been associated with these thrombotic episodes and clotting disorders. So I think we need to have a positive message there, beyond the fact that the VAERS and other reporting guidelines have seen the signal. But my other question also is, are these cases being investigated further in terms of autopsy? And I guess I could have asked that earlier, because is there something unique about, not having, with the messenger RNA ones, not seeing this? Is it something about the adenovirus vector? And is there anything in these, are autopsies being performed? Are these thrombi being examined? Are they finding the adenovirus vector within them? And maybe I'm being a little bit too simplistic. And certainly what is the inflammatory, signal there? Is there something within these clots that are different than other cases? And I just wonder if I just urge for more investigation, more autopsy specimens, and more and looking at these thrombi and seeing if we can see something in there that may have been triggered by the actual, whether it's the adenovirus vector or something else in the vaccine. Thank you.
Thank you. Dr. Goldman, please.
Thank you, sir. More of a comment as well. Certainly as a practicing internist, I'm really reassured that the VAERS system works. And I really want to reiterate what has been stated before, how important it is for my colleagues on the front lines to be utilizing it. And I really want to thank the CDC and ACIP for the on, as these clinical guidelines really do help us treat the patients on the front line. Now, in regards to the policy question, certainly short-term and long-term, as a practicing internist, for the immediate future, I'm definitely in favor of a pause as we see if more cases come out, because the true incidence of this condition may be revealed now that we've had so many more doses administered. And certainly, now that my colleagues are aware of this issue, I suspect more will be reported as it is recognized. But I would also suggest we consider the risk versus benefit of the vaccine compared to the risk of getting COVID itself and the potential of death from the disease. And we may lend ourselves more towards an individual decision on which vaccine the individual may want to choose to get, although this could be complicated logistically. And in the long term, I really am hopeful we can see if this is an issue with the vaccine adenovirus platform or is it an issue with this vaccine specifically. Regardless, I really want to stress to the public that they need to remain confident in our process and the science regarding vaccines in general, and that we need to continue to vaccinate against COVID and so many other diseases, and not to let this sour their decision on getting vaccinated in general, because I really do believe the VAERS systems work and we do have confidence in the process and that we'll make the right decision regarding public safety. Thank you.
Thank you very much, Dr. Goldman. And I just want to make one more comment regarding the data that was presented by Dr. Oliver. As usual, an excellent presentation, but the data on race and ethnicity is notably weak, in my interpretation. I don't know where we are on the exact number today, but as of 3 or 4 weeks ago, only 50% of those individuals receiving the vaccine had provided information regarding race and ethnicity. So I caution you on making any extrapolations based on the data that we have at this time. And so with that, we're going to proceed to this discussion. And Dr. Oliver, would you please start us on this issue and put up the questions that we are to consider, and then we'll open it up for a discussion.
Yes, thanks. So the questions that we brought before ACIP today is, does ACIP have enough information to make interim age or risk factor-based recommendations for use of the Janssen vaccine? And then what recommendation does ACIP feel is appropriate today, given the currently available information for use of the Janssen vaccine?
Thank you very much. So as we begin, let me point out to the voting members of the committee that we do not have to arrive at a vote today or a recommendation today. If we need more information, if we need more time to think about this, we can reconvene later this week or this weekend if necessary. This should be a considered vote based on the data that you all need. Having said that, I'd like to direct some words to the general public that are watching us and listening to these presentations. It's been stated multiple times throughout this meeting that safety has been a paramount issue in our deliberations for this vaccine, for recommendations, and for following the vaccine. As we started our deliberations in April of last year, that was foremost on the list of things that we needed to keep in mind, and we are doing that at this time. The FDA has stated the same, and pharmaceutical companies have stated also that safety is the ultimate goal here in the vaccine. Our systems for identifying these rare adverse events work, as pointed out by Dr. Shimabukuro and others. The fact that we have identified these very rare clotting incidents points to the robust safety systems that are in place and make our vaccine safety systems some of the strongest in the world. And I think it's important for the public to understand that as we go forward with new vaccines, we continue to have ongoing safety checks. With regard to the issue of vaccines and in general in the public, I think we all know that we are encountering vaccine hesitancy or reluctance regarding the use of these vaccines for the prevention of disease. Dr. Goldman spoke to this, I think, just now, and we need to have a decision and come to a decision regarding recommendations in a timely manner and ask if we do pause, that the pause be sufficient to address the question. This is an issue of safety and risk-benefit analysis. We may not answer all the questions at this time, but we need to come to a decision on this in an appropriate time frame and not delay it. This reminds me of the talk that Dr. Frieden gave us when we were discussing a pneumococcal vaccine. And we have the data before us. We need to act on that data as appropriate and add to that data as we go forward to modify or to strengthen it. So I'll turn it over to discussion at this time. Let's begin. I believe Dr. Fry has her hand up first. Please.
Thank you. This is Sharon. I'm just curious what the working group had discussed regarding just clotting in general and DVTs or PEs or what have you in general, and whether that was taken into consideration. I know that we're talking about CVST here with thrombocytopenia, and that's very unique, but is there an increased incidence also in clotting without thrombocytopenia? And did the working group talk about this at all, or there clearly is not an increase, or how is that factoring in the overall picture? Maybe Beth, you might.
Sorry, Sharon, are you talking about other clotting events with thrombocytopenia?
Without.
Or are you talking about clotting events in general with or without thrombocytopenia?
The latter, with and without thrombocytopenia. Was there an increased incidence of that in general also?
We did not focus on that.
Okay. Thank you.
Thank you. Dr. Long.
I would just echo what Sharon said. You know, the thrombocytopenia, which is so telling here, it may be, only very severe, and it may be only severe that really gets your cerebral sinuses. So the others are much harder to figure out because the underlying occurrence is so much higher. But I would think we are ready to make an interim decision to continue a pause for at least a month until we see what else comes out about does it occur in men. We now, in the most recent weeks, are immunizing younger and younger individuals. And we might be able to make some risk-related, more definitive potential use of the vaccine again in a month. But I suspect, because of what we know now, that this occurrence of these events has been in half the number that we have as the number immunized, considering when they could have occurred and could have been reported, and that we are going to get many more things occur in the next month that will help us with a more definitive. So I would be very much in favor of a continued pause, and I think I would be opposed to continued use at this time.
Thank you, Dr. Long. Dr. Bernstein.
Thank you. I wanted to make sure that I understood Dr. Fink's statements representing the FDA. Did I understand a risk management approach, and which included warning statements? And I was wondering what was meant by warning statements and how that actually would be operationalized in the real world.
Thank you for that question. The warning statements that I mentioned would be warnings in the EUA fact sheets for healthcare providers and recipients that are given to vaccine recipients at the time or before actually the vaccine is administered. And the risk management approach would be warning statements in combination with other communication from FDA, CDC, and other sources.
Thank you. Yeah, the EUA fact sheet is multiple pages as it is. And many of the people receiving vaccines are not having an opportunity to talk with their own provider about it. So there might be a disconnect in some way.
Thank you, Dr. Bernstein. Ms. Bata.
Sorry, trying to find my unmute. As I've been hearing this data and understanding how rare this event is, and what I've heard in conversations over the last 24 hours, there's two sides of this. There's you're overreacting, and then the other side is you should just stop this. And I know that there's been consideration of a provider risk-based discussion about continuing to use the Janssen vaccine for those who would feel comfortable. But I think that I'm coming on the side similar to what Dr. Long and Dr. Fry have said, that it would be helpful to have some additional information. And by having a little more robust information, I think we can be much more confident in how we talk about the safety of this vaccine. Because right now, the confidence for COVID vaccines is just right at a precipice. We've got people that can't wait to get it, and others who have been waiting and seeing, and this will, I think, contributes to that confidence that people have. And so I would be in favor of getting more information.
Thank you, Dr. Alt.
Well, my question or comment is kind of a corollary to that. How did the working group discuss how much longer they would need to get this information? I mean, we do have a meeting scheduled May 5th, which is 3 weeks from now, not a month from now. And I was curious to know, what the logistics were there.
This is Dr. Bell. I would say that there sort of wasn't a final conclusion about how long would be necessary. I think there was a general sense that there needs to be enough time to provide the kind of data that the working group felt was necessary, but also that it was extremely important to do this as expeditiously as possible because of all of the potential unintended consequences of a prolonged pause.
Thank you. Dr. Talbot.
Yes, so I probably will reiterate some of what other people have said, and pardon me for doing that, but I want to say up front, we are very fortunate because we have multiple other alternatives in the U.S. to help stop this pandemic. And we have very good, well-proven alternatives that we are not seeing safety signals in. So I think that puts us in a little bit of a different position, and we can be much more cautious and thoughtful and use the old motto of first do no harm. And so I think truly in a setting where we don't have enough data for other thrombotic events such as stroke and DVT and PE, we should have the time to do that. I also think we're in a setting where the usual treatment may be rather harmful, and so we can't say, oh, this is treatable, let it go. Thirdly, I think we don't know enough about age yet. My suspicion is that events like strokes may be underreported or not flagged, and these occur more often in older adults. So I'm very hesitant to say it does not occur in anyone over 50. So I feel like we're fortunate and have the opportunity to wait a period of time and continue to hold until we have this information, and strongly encourage people to continue using our messenger RNA vaccines that have proven to be safe and effective until we know more. And if we can say the Johnson & Johnson vaccine is incredibly safe and we're not worried about this, we will come back and say that. If not, then we've done no harm and we've been able to continue vaccinating in the meantime. Thank you.
Thank you, Dr. Talbot. Dr. Sanchez.
Thank you. I agree with Dr. Long and the others. I think that a continued pause is what I would favor and recommend. At the current time, I am not continuing vaccination of any individual with this product.
Dr. Sanchez, thank you. Dr. Bell.
Thank you very much, Dr. Romero. I thought I would just give my own view on this topic so that, I have an opportunity to comment. Basically, to be very frank, I do not want to vote on this issue today. I do not want to vote not to recommend the vaccine. I think that is not really something I necessarily believe. But I do not feel that we have, it's not surprising. We've, been kind of looking at this issue for 2 days or less. I just don't feel that we have enough information to make an evidence-based decision. We won't have all the information, but I think there are some things that we can gather relatively quickly, which all have to do with the benefit-risk balance. We do need to better understand the risk, which we know is going to be very rare, very low, but we really don't know exactly how low and how to correctly characterize it, what the denominator should be, what is the numerator, how many cases are there with thrombocytopenia that is not CVST, as an example. So there's a number of things like that. Second, we need to understand that risk, whatever it is, in some kind of context, with other things that might cause thrombosis, for example, because I think that it's important for the public to understand when we say rare, what does that mean with respect to other risks that we might take every day. And then thirdly, I think we need to, have some sort of formal risk-benefit analysis that allows us to very clearly point out to the American people why we think it is the risk-benefit favors whatever the recommendation is that we end up with. I mean, I want to be able to, feel comfortable with my family members, myself for that matter, to receive this vaccine. Nothing is risk-free, and as people have said, we are ahead of ourselves here because we so quickly identified this and because of what's been going on in Europe. So the bottom line of this long exposition is I do not think we should vote today. I think that the implications of a vote not to recommend are stronger than I at least want to, I do not want to send that message. So I think we need to not vote and gather the necessary information so that we can make an evidence-based decision.
Thank you, Dr. Bell. Sorry, was that Dr. Cohen?
Yes, I just wanted to add and clarify that we do have a scheduled meeting on May 5th, but if we need to have, if the ACIP, if we can pull together information and we can come back before that period, we don't have to wait until May 5th to have a follow-up discussion.
Thank you, Dr. Cohen. So, sorry, Dr. McDowell, let me just say this and then sorry, Ms. McDowell, I'll turn it over to you. Yes. So that was, certainly one option that we could consider is that to continue this pause until our next meeting, or we could meet sooner if there is more information that allows us to make a final vote, a more concrete vote prior to that time. I think, as Dr. Alt pointed out, and now Dr. Cohen, that we have another meeting in 3 weeks. And that would fall in this period of a pause and allow us to get more information and see what more cases come forward. Ms. McNally, please.
Thank you. And I think I may have a clarification question of Dr. Shimabukuro. So it seems to me that it's very reasonable to try and gather more data. And if I understand it correctly, from the cases that Janssen talked about that were reported directly to Janssen, ultimately those cases were reported to VAERS. And I'm just wondering if Dr. Shimabukuro can comment on what might be a reasonable period of time for us to gather more data and reevaluate. Thank you.
Well, if you look at the, I have to pull up my own presentation here. I think the median onset was 8 days, 6 to 13 days. So you've got individuals who have been vaccinated who I think we want to follow out for what we think is maybe a reasonable risk window, and time to actually capture any cases that might be identified, and that capture and evaluate any cases that might be identified in that risk window, which looks like about 1 to 2 weeks. Plus, I mean, there may be cases out there which have not come to our attention, but might come to our attention now that this information is out there. We call that's a reporting bias called stimulated reporting. So I do think in the coming weeks we are going to gather more information. We're going to continue to gather more information, we will continue to get better, more specific information as we can access the medical records, where we'll get a better picture of what's going on. We are going to refine our observed versus expected analysis. I know that the folks at the FDA are working on that. So I think in the coming weeks, we will have more information and better information where we can assess the signal and possibly characterize the risk.
Thank you.
Thank you.
Dr. Fry.
Thank you. I was just wondering, a question for Dr. Shimabukuro. What is the delay in entering data into VAERS? So if someone has an adverse event, such as a CVST, how long does it take for the physician to actually report that data after the event? Thank you. On average.
Well, I mean, the decision to report, report really happens at the healthcare provider level. We encourage that there are reporting requirements under EUA, and this would constitute a serious adverse event because these individuals, at least for the 6 that we've observed, are all hospitalized. So this would fall under the emergency use authorization reporting requirements. CDC's recommendation is to report an adverse event as soon as possible after the onset of symptoms, or after a person or a healthcare provider becomes aware of the symptoms. So we want to get these reported to VAERS as quickly as possible. That's one part of it. The other part is how quickly do we process, follow up, and analyze these reports. And I mean, because we were following these reports, these types of reports closely because of what was happening in Europe, we are basically reviewing these in collaboration with FDA is in fairly close to real time. They come in, the categorization of serious or non-serious is made known to us quickly. We can review these serious reports. We can identify potential CVST or other thrombotic events. And we can expedite records collection, where either we direct the contractor to expedite collection on a specific report, or we just simply do it ourselves. So we have ways of compressing that timeline, and our focus now is to make sure that we identify and follow up and assess and analyze these reports as quickly as possible. So I think on our end, it's a fairly quick process, and based on the reports that we've seen that have come in, providers are reporting those in a timely manner as well.
Thank you. Dr. Lee.
Thank you. Sorry, you're going to have to bear with me. I've been thinking about this for 48 hours, and so I wanted to just make a few statements and put out a few requests. everyone acknowledges that risk is an inherent part of life. We would not be vaccinating anyone if there weren't a COVID-19 pandemic ongoing right now. But there is a population level benefit risk balance that we need to consider and individual benefit risk balance. I think the role of ACIP in this instance is to focus on mitigating that risk. We also need to better understand the benefits, because I've also seen patients, and I know many of you have, admitted with clotting disorders and thrombocytopenia, sometimes immune-mediated thrombocytopenia associated with COVID-19 disease. So we really need to have a balanced picture of both the benefits and the risks. From the ACIP perspective, I think there are 3 things we can do to mitigate risk. One is to identify populations at the highest risk for this potential complication and adapt our recommendations to minimize exposure to those at highest risk for this potential adverse event. The second is to educate patients about the benefits and risks of different vaccines and to ensure that patients seek care in a timely manner. And the third is ensuring that our healthcare systems are able to diagnose and manage these cases in an incredibly timely way. Because if we can manage these cases early and well, similar to anaphylaxis, we may be able to employ strategies that change the outcomes that we see with these patients. So that said, I also just have to comment that, this is so challenging because the impact of ACIP decisions on the global stage is clear to me, given our past experience with rotavirus vaccines. And I think that the benefit-risk balance may be very different in other countries where vaccines are either not available or not feasible for widespread implementation. And I recognize that our responsibility at ACIP is to individuals in the U.S., but I also feel the weight of the burden of a global responsibility that we also have and the impact that our decision-making could potentially worsen inequities. So regardless of whatever decision we make on this particular safety signal, I think it's important for us to make sure that we're collaborating with partners outside the U.S. to address those inequities in whatever ways we can. So then thinking about what we need to do ahead, what information is needed before I think a vote can be taken. I agree with Dr. Bell. I don't think we have enough information today. I think we need to go through the signal refinement phase where we can capture age and gender stratified rates of CVST and the outcomes associated with CVST among both vaccinees and those with COVID-19 disease. That we have a better understanding of risk factors associated with CVST and those who have poor outcomes associated with CVST. We need to review the data across multiple vaccine safety surveillance systems, and I wholeheartedly agree that we need a formal benefit risk assessment to make a well-informed decision. We also need to move through the signal refinement phase, I think, as quickly as possible in order to be able to support evidence-based decision-making. So, and I know everyone knows this around the table, but we really need strong collaboration across the federal agencies and with global partners in order to be able to make the best possible decision in as timely a manner as possible, because I continue to feel we're in a race against time and the variants, but we need to do so in the safest possible way. Thank you.
Thank you very much. Dr. Cotton.
Thank you. Grace, I very much agree with what you said. I would just like to add that the putting this vaccine on pause for those of us that are frontline healthcare workers has really been devastating. I agree in general that we don't have enough time, or we don't have enough data to make a decision at this time. But we were planning on using this vaccine in the state of Massachusetts for people who are homebound and otherwise not able to get a vaccine. We were planning on using it for our vulnerable inpatient population, often with many comorbidities and at high risk for disease, but who haven't been able to get vaccinated otherwise. And then it certainly was going to be used in what may be otherwise underserved populations or populations that aren't able to get mRNA vaccines. So I definitely want us to be cautious and very careful with our decision making, but I also just want to emphasize that this one and done vaccine that didn't require the cold chain that the mRNA vaccines do is, it's a significant loss. And I just wanted to highlight that for sort of the underserved populations that did need access to this vaccine. Thank you.
Very good. Any other comments from the voting members? Dr. Cohen, we have a hand up from one of the liaisons. Are they allowed to comment at this point?
Yes, that would be great. We can move to some broader comment. Before we do, I just want to summarize a couple of the things that I've heard and give some potential options moving forward. It sounds like we have certainly heard that there's a need for more of a refinement of the risk as well as risk-benefit analyses. And I just want to remind everyone that the goal today was to be as transparent and communicate information as rapidly as we had it available with the ACIP members, with our liaison organizations, and with the public, knowing that some of this work we will be doing around the clock over the next several days. So we are working on those analyses. I think one of the questions for ACIP today is, with what we've been presented and not having that additional information, is ACIP comfortable preferring to continue the current pause or not make any decision about this at this time? Or is there or do people prefer to refine or to make a recommendation around shifting the pause for a short basis, potentially, for example, pausing just in a certain population versus the entire population that is currently paused at this time? So when the word interim is made, that interim shift can be for just a week or two as we try to refine. I know typically when we make interim recommendations, we're thinking for longer periods of time, but there are lots of different options here, including just just waiting for more information. But I do think that there's a critical question about if the pause should continue for the whole population, as some have indicated, versus should that potentially be refined?
Thank you. Let me turn to other comments now. Dr. Shah.
Thank you, Dr. Romero. Good afternoon again, everyone. This is Nirav Shah. I'm speaking in my capacity as president of the Association of State Territorial Health Officers. I'm also the director of the State of Maine Center for Disease Control. And I must express concern about the direction that I fear the committee may be going. We are in a situation where not making a decision is tantamount to making a decision. Any extension of the pause will invariably result in the fact that the most vulnerable individuals in the United States, who are prime candidates for the Johnson & Johnson vaccine, will remain vulnerable. The most at risk will remain at risk, and those who would benefit immediately from vaccination will remain unvaccinated for an unknown period of time. That would come at a period where the United States is still logging 5,000 deaths in the past 7 days just across the country, and at a time when there were 489,000 new cases just in the past 7 days. The initial reason for the pause was, among others, to ensure that healthcare providers and recipients were apprised of the possible risks, as well as to be on the lookout for them so appropriate treatment could be given. It's always possible to get more data, and indeed, in the history of pharmaceuticals, we are always refining our understanding of risk. That's always part of it, but there are also tools available today to better evaluate and mitigate that risk while continuing the provision of the J&J vaccine. I would urge that any pause be counterbalanced by consideration of the equity considerations that would befall from any lengthening of the pause.
Thank you very much. Dr. Freihofer.
Sandra Freihofer, liaison for the American Medical Association, speaking as an individual, as a practicing physician. I must tell you that this whole process today has really increased my confidence in vaccine safety. I greatly appreciate the honesty and transparency and the quick action that the FDA and the CDC have taken. I have listened to the comments from our esteemed group of ACIP members, and I hope that when the membership does vote, that they will, that I personally hope that they will support some pause so we can figure out if this is a needle in the haystack or the tip of an iceberg. There are other vaccines available. There is a supply of these vaccines, and I am so sensitive to the equity of vaccine distribution. I know that there are many patients that have not been able to get vaccinated, that need to get vaccinated, but we want to make sure these vaccines are safe. And I do think a short pause to give us a chance to collect this information, to give physicians and patients time to, to understand what we've been talking about, and there might be more cases coming out. But at the end of the day, I just really respect the process, and I'm proud to be a part of it.
Thank you very much, Dr. Freihofer. Dr. Talbot.
Yeah, I just wanted to say briefly that I do appreciate the comments about getting to those who are homebound and are difficult to find. I do, however, want to say that I am also worried that those that cannot get to the medical care and those who are difficult to find may be at risk for severe clot if they do develop clot and may not get to care in enough time. So it is a double-edged sword, and it is concerning. And I think that's why many of us would like the risk-benefit analysis so that we can help figure that out. Thank you.
Thank you. Dr. Dushin.
Thank you. Jeff Duchin, Infectious Diseases Society of America. I would just like to reemphasize for the public that what we're talking about is a very rare, albeit serious, event that's associated with a vaccine that was detected through our vaccine safety system. And that if the ACIP elects to pause further, it should not be interpreted as a signal that there is an increased concern about vaccine safety today beyond which was evident initially, but a desire to better characterize the risk in order to make the best possible guidance going forward. Thank you.
Thank you very much. Are there any other comments from the liaisons or the working group members? I'm not seeing any new hands. I'm not seeing any. Oh, Dr. Long, please.
We didn't really answer the question for Dr. Cohn about could we parcel out any less at risk, more at risk groups in rather than just an universal pause. And I think we would be uncomfortable with that because, the lack of specific and large data that would help us decide this person is less at risk, more at risk. Certainly everybody is at risk, and although it's a very small risk, it is so serious. I mean, this could be limb, life, it could be a severe consequences for your life, neurologic consequences. So I think that there would be, although I understand the unintended consequences, I think we can live with the unintended consequences because the amount of vaccine that we do have, and it would be the wrong message and a real mistake to the people who would be getting this. We're not able to inform them accurately at this moment about the benefit, the risk. So I think that we can't parcel out groups that are more or less at risk because we don't have enough information. And I would speak again in favor of a pause until we have better data.
Thank you for those comments. Let's see, is Dr. Lee?
Yeah, I just, reflecting on Dr. Long's comments, I do think that, obviously all of us care very much about safety and individual and population benefit risk balance. I'm struggling with the idea that I don't think an indefinite pause is a good thing. I just think we're going to have whatever data we have and make a decision. I think the main question I have is whether or not we think we can assess where we are in another week or two. Even in the last 48 hours, a tremendous amount of data has come out, and work with our colleagues to come up with a sort of a time frame for this. But I think an indefinite pause is, as Dr. Shaw mentioned, functionally a decision, and I would not advocate that because that is not the decision I think that makes the most sense.
Dr. Lee.
Dr. Bell. Sorry.
I was just going to respond to Dr. Lee. I completely agree that we definitely don't want it to feel like an indefinite pause. And I think just if ACIP, from a process perspective, if there is no motion or desire to vote on a recommendation today, that would result in us going back to work as quickly as possible and coming back with an additional emergency meeting in a week, 10 days, 2 weeks at the most, but we will try to get the work done that we need to get done to present to you as quickly as possible. And we would, try to provide enough information for a decision at that time.
Thank you very much, Dr. Cohen, for providing that time frame. You anticipated my question. Dr. Bell.
Yeah, actually, actually anticipated my question as well. I do not want to be sending a message that we are more concerned, that there's a message that there's some huge concern here of a different order of magnitude than any other vaccine safety signals that we evaluate, because that's not the message that I want to send, and I don't want to send a message that there's something fundamentally wrong with this vaccine, because that also I don't agree with. So whatever the process is that allows us to, as expeditiously and quickly as possible, have enough information, which is never all the information, but it is hopefully a few of the kinds of things that a number of people have mentioned that are important and are necessary, as quickly as possible. However we do that, however we can do that, and Dr. Cohen, sounds like you've just explained it, that's what I would like to do, because, as I say, it's a very rare event. Nothing in life is risk-free, but I want to be able to understand and defend a decision that I've made based on a reasonable amount of data.
Thank you. I don't want to cut the discussion short, but I just want to make sure. Dr. Cohen, is there a time frame in which you must end this meeting because you have to leave that building where you're in, or can we continue as questions keep coming up or comments come up?
We are fine continuing the questions. I think that if we could shoot for 5:30, that would be great. But I don't want to cut the conversation short.
Perfect. Thank you. Neither did I. So let me see here. Dr. Alt, is your hand up?
Yes, I just wanted to go back to Dr. Bell, because really the point of my question that I asked earlier was I don't want an indefinite pause either. That's why I was curious about what kind of time frame we were talking about. So I'm reassured hearing that this could be a relatively short amount of time.
Thank you. Dr. Bernstein.
Yes, I agree. I would not want this to be an indefinite pause. Maybe Dr. Oliver can answer this. I was interested to know how many J&J vaccinees can we expect data from, in what time frame, looking forward over the next week, 2, 3?
Can anyone hear me?
Yes.
Yep. Okay. Dr. Oliver, did you have an answer for that?
Okay. Can you hear me now?
Yes, we can.
Okay, perfect. I think I had a mic issue earlier. So the 3.8 million doses were administered in the last 2 weeks. I don't have a further breakdown on each week. As Dr. Shimabukuro mentioned, we expect some stimulated reporting now that all of this is out, and that we're highlighting and kind of asking for reported cases. So we would expect that the delay between presentation and diagnosis, and then diagnosis to reporting to VAERS, would actually be, a much faster kind of turnaround now that the HAN and other, educational methods are out. So we'll have to see, but I think we anticipate, that we could get additional information on cases. If they're out there, we will find out about them hopefully relatively quickly.
Thank you. So I see Dr. Dushan's hand is up. Did you want to ask another or make another comment, Dr. Dushan?
Sorry, taking it down.
No, just making sure.
Thank you.
And Dr. Alt, yours is still up, so I just want to make sure. Dr. Shah?
I must express concern again over this line of concern or discussion. My concern is as follows. I understand the rationale behind the pause, but we should also have a theory of lifting the pause. And if the concept of operations right now is to simply accrue more data without a theory of what those data may mean and how we might evaluate them, it is just as possible that the committee may in 3 weeks say, well, let's just hold on for even more data. So if we are going to have an extension of the pause, we should at least couple it with the theory of what lifting the pause may look like and under what criteria we would do so.
Thank you, Dr. Shaw. Dr. Lee.
Thank you. I'm hoping I can respond to this, at least with my own opinion. To me, it's not data in terms of having perfect data, because we'll never have perfect data and there will always be uncertainty. But it's really, for me, about getting better risk estimates and understanding action or recommendations, if we can, to minimize exposure to those who may be at highest risk for this particular adverse event. It's possible we may not have any more information, in which case I still think we're going to have to make a decision or a recommendation at that time. But I think that my hope is that in the next week or two, we can actually capture that in a more robust way, because I feel like the benefit-risk balance to me is unclear without having the risk estimate of this particular potential adverse event by age, by gender, and understanding other risk factors that may contribute. So that's my hope, but I agree we need to make a recommendation soon.
Thank you. Are there any other comments? I see no hands at this time. So am I summarizing it correctly that we are not ready to vote at this time?
Dr. Romero, what I'm hearing from the ACIP members and liaisons is that there is a strong desire to reconvene as quickly as possible after both some risk benefit as well as additional risk refinement has been done, which we will do, which we will commit to at CDC is doing as rapidly as possible. And at this time, ACIP would not provide any, does not wish to vote or put any motions on the table to vote for a change in the current recommendation. So while the recommendation is paused, we would still have our current recommendation, and we would continue to pause on that until, or we would, CDC would likely choose to pause on that. I can't confirm, but this would be providing no recommendation to our director until we meet again in a week or 10 days.
Excellent. Very, very good. Does anyone on the committee have a opposition to that? Okay, I guess seeing no hands, Very good. That's, as you said, Dr. Cohen, we will go forward.
Great. Then I think the meeting can be dismissed, and we will find a time to reconvene. We anticipate today is Wednesday. We'll try to identify what that date is by Friday of this week so that people have a little bit more time to get it on the calendars, and we will and we, appreciate all of your time and all of your guidance and expertise that you've provided us today. Even though we did not make an official recommendation, your input today was incredibly helpful in terms of helping inform our work over the next week.
Thank you. So with that, meeting adjourned, and we will wait to hear when we will reconvene. Thank you very much.
Thank you.
Goodbye.